Rajasekaran sir, you'll start, right?
Yeah.
We're live in 3, 2, 1.
All right. Good evening to all of you. So, welcome to the second in the series of the Ganga webinars, which we are doing in association with OrthoTV. The first one was trauma and was a huge success. And the plan is that we will have on alternate months webinars on trauma, and the other alternate months will be on specialties like spine surgery, pediatric orthopedics, sports medicine, foot and ankle, and arthroplasty. Thank you again to all of you for joining us. And for the first on the spine webinar, we have chosen the topic of lumbar disc surgery. Now, lumbar disc is the field through which everybody gets introduced to spine surgery. However, though it looks simple, it can be really challenging because it needs a lot of judgment in the preoperative decisions, intraoperative techniques, and also in the postoperative management. And for this, we have a very good galaxy of good faculty members, my own colleagues, Dr. Ajoy Shetty and Rishi Kanna, and our previous alumni, who are all worthwhile spine surgeons now, Dr. Naresh Babu from Guntur, Dr. Janardhana Aithala from Mangalore, and Dr. Thomas Kishen from Bangalore. We also have three guest faculties from OrthoTV, Dr. Siddharth Iyer, Dr. Nitin, and Dr. Ayush Sharma. And my thanks to all of them and welcome to all of you. So without further ado, we will just go on to the first topic of Ajoy Prasad Shetty on clinical examination. Ajoy, over to you.
I share the screens. Good evening, everybody. It's my pleasure to be here today. My talk is basically the clinical evaluation of low back pain with emphasis not only on the examination, but more emphasis on the history. We do know that low back pain is one of the most commonest symptoms what everybody sees in their day-to-day practice. The second most common in general practice, and one of the most commonest what we see in orthopedic practice. But what is important is the fact that globally there is a 54% increase in the last 25 years. It's probably because of increased longevity of the people, associated comorbidities, and also affordability and awareness. It is important for us because the pathology may be different. It could be infection, tumor, trauma, or a degenerative condition, the most commonest cause, but all of them present similarly with back pain. Therefore, it's important, especially in Indian scenario, that we should be able to come to some sort of a reasonable diagnosis at the end of our examination and then ask appropriate investigations, because affordability is one of the major concerns. Not every patient can move on to have an MRI scan, and also unnecessary use of investigation also we should avoid. We do know that low back pain is a symptom. It's not a disease. The causes could be intraspinal or extraspinal. We do know the common causes of back pain, the degenerative causes, inflammatory, infection, trauma, metabolic, and neoplasm, of which the degenerative is the most important cause. But we should also remember the fact that not all low back pain comes from the back. It can come from SI joint, it can come from the hip joint, sometimes the cause may not be identified. Therefore, we should also remember there could be non-spinal causes of low back pain, which could be coming from the abdominal organs, it could be coming from the vessel, or it could be psychogenic also. And this particular slide highlights the importance of looking through all the aspects and also a cause for a non-spinal cause of low back pain. The patient underwent a surgery for a presumed L4-5 disc. Symptoms did not resolve, but if you look at the MRI carefully, you can see this patient had an aneurysm of the aorta, and this was the one which was causing symptoms to this particular patient. What we know is also non-specific low back pain is the most commonest. The first episode of low back pain, 95% recover and stay pain-free. Recurrence could be common in those individuals with high intensity pain, longer duration of first episode, greater than 2 episodes. If the episodes keep happening, it's recurring, then the chances of recurrence is comparatively more commoner. Lower socioeconomic status. Now, what is low back pain? It is the pain between the lowest rib and the crease of the buttock. Whereas sciatica is a back-related leg pain, that is the pain which is radiates from the back down to the legs. But you should remember, it may not be a back pain at all. I mean, they may not have back pain at all. It could be only a leg pain. It could be acute, subacute, or chronic. What we'll be discussing mainly will be chronic low back pain, which could be an axial low back pain, which just extends up to the mid buttock. It could be low back pain with radiation, which can go up to the posterior or the anterior aspect of the knee. Or it could be low back pain with the radicular component. That means the component usually, because if you look at the lumbar spine, the lower lumbar discs are the one which are usually more symptomatic. If you take it, the L4-5, L5-S1 are the most commonly symptomatic one. And therefore, it's more likely that the symptoms will go down below the knee joint. A radicular pain at the L3 dermatome, that is at the L2-3 level, can go up to the only up to the knee, which can mimic like a radiation pain. But most of the problems being at the lower lumbar, it radiates below the knee. What is important when you evaluate a patient, any patient for that matter, and more so in low back pain, is the age of the patient. Because moment you put the patient into a particular age bracket, you have somebody, a 30-year-old man who comes with early morning pain, and say progressively the pain becomes better with activity. You know it's an inflammatory type of back pain. You think of seronegative spondyloarthropathy. A patient who is 50 years who comes with a walking distance progressively decreasing, a claudication, you think in terms of spinal canal stenosis. Therefore, age is very, very important. The next important thing for me is the gait, as to how the patient is walking inside to your outpatient department. He's walking comfortably, he's walking with the list, he's walking with difficulty. There is a forward stoop. It gives an idea about the severity of the problem, whether the patient has got a significant problem or not. And these two, I mean, this along with proper history taking will help you to come to a diagnosis much more easily. The idea is that these are the common symptoms: pain, deformity, weakness, gait disturbances, bladder and bowel symptoms. When they have weakness, gait disturbances, bladder bowel symptoms, it's usually easy for us to understand that the problem is severe, and we will definitely ask for a higher investigation like MRI. But what is important is to identify what is the type of pain and come to a diagnosis when the patient has got only back pain. Therefore, the pain could be mechanical, it could be discogenic, it could be inflammatory, it could be instability type, or it could be non-specific. Mechanical, as the term implies, it is pain-free in the morning, increases by activity and decreases at rest. Whereas discogenic is a deep midline back pain. Sitting may not relieve the pain. Actually, sitting activities like coughing, which raises intrathecal pressures, actually elicits the pain. Inflammatory back pain, as I mentioned earlier, happens in patients between 20 to 40 years of age, early morning stiffness, and the pain decreases with activity. Gluteal pain may be present, which may be, and in the later stages, restriction of movement. But here we have to differentiate inflammatory back pain from instability pain. Both in instability also there is early morning pain, but the pain is very severe. The patient is unable to get up from the bed, and they roll around in the bed and get up slowly. By the time the muscles go into action, they become spasmodic and helps stabilizes the spine, and the pain becomes better. When you have a radiating pain, you should be sure whether it's a radicular, neuropathic, or a claudication. Claudication you are all well aware of. That is, patient says when he walks for some distance, the legs go numb. Especially more common in patients above 40 to 50 years of age. Whereas radicular pain, most of the patient pain starts from the back, go down to the leg. Whereas a neuropathic pain is the one which is similar to a diabetic neuropathy, more so during the night time. It's a paresthesia rather than a pain. That is an altered sensation. Therefore, that's what is important to differentiate. The pain becomes worse when they are inactive, especially during the night time. And it's important for us to identify, when you are taking the history, the red flags. What is a red flags? It basically helps us to know whether the patient has got a severe pathology and helps us to decide whether we need to move into a further investigations. There are determinants, that is the elderly patients, diabetics, immunosuppression, or there could be clinical features like unexplained weight loss, neurological weakness, trauma, fever, and the rest pain, especially pain more during the rest or in the night time. Therefore, whenever there are red flags, it's important that we need to move on to a higher level of investigation, a high index of suspicion, and MRI might be warranted even at the first visit. You do know that yellow flags, that is the predictors of poor outcome, that is a psychological overlay, also is very, very important for you to look at. And it's much more important when the patient has got an incidental lysis or a listhesis, but symptoms are more generalized. You should be very wary of the fact that you are offering surgery in case you are offering surgery for the lumbar back. Neurological history is very, very important. If the proximal muscles are weak, the patient says the climbing stairs is difficult. Distal muscles are weak, holding the footwear, buckling of the toes while walking is much more common. You do note the classical spine examination, the look, feel, move, neurological examination, the special test. I'm not going to go into that, but for me, gait is one of the very, very important aspects. I mean, you look at the gait, you start observing the patient as soon as he is walking inside into your operating room, before the patient even recognizes that he is being examined. And look at the pattern of gait, the ease, the fluidity, whether there's an awkward gait, whether there is a pain element, whether there is a list that is associated with the patient. A presence of a list, an acute onset list is usually very, very characteristic of a disc prolapse. You do not see an acute onset list in any other condition. And usually it implies to us that patient has got an acute disc prolapse, which could be just a tear in the disc could be adequate, or it could be a prolapse of the disc. Neurological examination, for me, always it should be in the order, start from higher mental functions, examine the cranial nerves, examine the upper limb, and then do the lower limbs and the myelopathic signs. Just because the patient comes to you with low back pain, do not start with the evaluation of the lower limb neurology. As a rule, start from the higher mental functions to the down, so that you do not miss any chance of a tandem stenosis or a stenosis or a myelopathy, which is pre-existing in this patient with the lumbar canal stenosis. All of you are aware of the simple test, the heel walking, which is basically looking for the L5, toe walking, which basically finds out subtle neurological weakness, which is due to the S1 nerve. And we do know that SI joint is also one of the commonest causes. You have tests in supine, you have tests in lateral, you have tests in prone. Therefore, there are 6 tests which you can do for the SI joint dysfunction. If you've got 3 of the test is positive, and these tests usually will be associated with a positive diagnostic injection into the sacroiliac joint. The nerve root tension signs are very, very important for us, and nerve root tension signs are usually found only in a patient with acute disc prolapse. Because it's not because due to compression, it is mainly because of the inflammation which is existing along with the compressive element. Because the disc, when it comes out from the nucleus pulposus, once it comes out and exposed to the body fluids, it elicits an inflammatory response. And that's why SLR is usually positive. And the positive SLR usually indicates a disc prolapse. You do not get a positive SLR in the patient with a lumbar canal stenosis. However, you have to be sure that this restriction of SLR is not due to a hamstring tightness, but only because of the pain which is radiating down from the back down to the legs. And once you have done all that, you have to think you should have a differential diagnosis, whether it's a radiculopathy, whether it's a discogenic back pain, whether it's a mechanical back pain, whether it's an inflammatory type of back pain, and then proceed accordingly. To summarize, history is very important. Always focus on the red flags. Be sure that you have ruled out severe diseases or serious diseases before you think of managing them conservatively. X-rays is always a must. Whether to get an MRI or not depends upon the presence of red flags, persistent of symptoms of more than 3 to 4 months, disability of the patient. But the investigation should be based on the history and examination, not arbitrarily for all the patient who comes to you. Thank you very much.
Thank you, Ajoy. So that was a very quick emphasis on what all spine surgeons know very well, that clinical examination forms the center foundation for your diagnosis in spine. So when you have a patient, Ajay, when do you start thinking of advanced, if they don't have, not all of them have red flag sign. So when do you go in for advanced imaging? What are you?
The basic thing for me is if the patient is coming to me with a chronic low back pain, then it depends upon the disability of the patient, how long the symptoms have been persistent, whether he has already undergone a conservative trial and still he feels it's affecting him significantly. That is only when the patient has got a low back pain, when he doesn't have a presence of a red flags. But if he has got a radiculopathy, I'll discuss with the patient. If there is no neurological deficit, if he's not significantly disabled, he's come for a 1 or 2 days of pain, it can be treated conservatively for the short duration of time, and majority of the patient do respond. But in an Indian scenario, there are certain scenarios when the patient demands that he wants to have an MRI. And I have learned out of experience that when the patient demands to have an MRI, I think it's always better to get it done.
Of course. Anything you want to add, Janardhana or Naresh or Rishi, even Aish, on the clinical evaluation of the patient? How often are you proved wrong? Because when we teach our residents, we always say, by the time you finish your history, you must have the diagnosis in your hand. How often do you feel that sometimes we are going wrong, and it's always better to, we still need to hold rigidly to the dictum that imaging should always come very late after you have tried some conservative treatment. In the other fields, things have changed. Because in pulmonology, they say that clinical examination starts with the chest X-ray. I mean, they say it's, why do everything like? So Thomas, when do you go in for advanced imaging?
So between acute back pain and chronic back pain. So if somebody comes in with acute back pain of a day or a few days duration, then I tell them that this is most likely to settle down on its own and probably does not require any investigation. Whereas if the patient has got long-standing back pain, I tend to divide them into 3 groups. Patients whose back pain is more in the night, patients whose back pain is more when they wake up in the morning, and patients with activity-related back pain. Patients who have got back pain which is more predominant at night, I would try to investigate them early just to rule out tumor or infection or one of those sinister pathologies. The patients who have back pain when they wake up in the morning, typically not the instability type, but for patients who had pain going on for a very long time, I send them off for an MRI at least to make sure that they're not dealing with a spondyloarthropathy. And if they have spondyloarthropathy in the form of sacroiliitis on the MRI, I send them off to the rheumatologist. Whereas patients who have got mechanical back pain, then I tend to see how much it is affecting their day-to-day activities. If it is just a very mild pain, I tend to treat them with some non-operative first, and if it doesn't work, then send them off for more imaging.
Okay. So with that note, I think I will start off on my talk on imaging for lumbar disease, what matters and what doesn't. Because as surgeons, we are only as good as our diagnosis, and as orthopedic surgeons, and especially on the spine, we rely a lot on imaging. Now, there wasn't a big problem when imaging meant actually X-rays, because X-rays were more specific and less sensitive, and you clearly knew what was normal and what was abnormal. When you saw something abnormal, it also meant it had a disease. But this was not so when newer imaging techniques or advanced imaging techniques like the MRI came, because they're very sensitive but less specific. And here the judgment of the surgeon becomes very important, because it can lead to overdiagnosis and treatment. So just like we say that there are 10 commandments to life, that there are some important things that we should not, we should be careful while we look at imaging. Number one is, do not sidestep clinical examination. Ajoy already mentioned about this. And whatever you do, the whole of the imaging does not have much relevance unless you have carefully examined the patient clinically. Now for the patient, they will always thrust the MRI in your hand because for them, the 8,000 rupees MRI is more valuable than the 400 rupees consultation to the surgeon. But without a clinical history and neurological examination, you can actually go very wrong. For example, this patient with walking disability came only with the lumbar spine MRI, but just making him walk, doing a clinical examination showed that he had a spastic gait, and then it proved that he had what he needed to be done was in the cervical spine and not lumbar spine. Similarly, the second important thing is do not overlook plain X-ray imaging in favor of advanced imaging. Now, this is a patient who required a disc surgery and you would have opted for a micro-discectomy. But just looking at the plain X-ray and looking at the stress X-ray, you can see that there is an obvious deformity, and what he requires because of the instability is a T-lift. Because if this stabilization has not occurred, there is a huge possibility that this patient would have gone in for a major post-disc surgery instability. Also, some of the other diagnoses like a simple lysis is more obvious on the X-ray. For example, this patient has got at L5S1 a large disc, but the plain X-ray actually showed that he also had a lysis at a level above. So this brings a critical evaluation of your judgment, but which you would have missed if you had not taken a plain X-ray. Now, once you decided to do the imaging, the most important question is, are all the disc prolapses seen in MRI relevant? Now, this is very important because MRI is very sensitive, but does not always indicate a disease. There are ample literature to show that when you take a lot of asymptomatic volunteers, even below the age of 60 years, only 36% of them have normal intervertebral discs, and many of them have disc protrusions and sometimes even extrusions. And abnormalities are seen at more than one level in 38%. And here you can see the famous paper by Scott Bowden that as you age, you develop a lot of imaging abnormalities over here. Now, this is very critically important, and that is the reason radiological findings are not very relevant unless they are corroborated by clinical symptoms. And this is what we call as clinico-radiological correlation. Unless you have the clinico-radiological correlation, when you operate, you get 90% success, but if not, your success rate can become as low as 40 to 50%. So your radiological, whatever you find, must correlate with your clinical judgment, both at the level and the side, and that's very important. So when there is a herniation, does size matter? Is there a difference between a disc which is smaller size to a disc which is almost completely blocking the whole spinal canal? Now, this paper in review article in JBJS obviously showed that small and contained discs respond better to conservative treatment rather than large and migrated discs, because it stands to logic that the compressed nerve root adapts to a new location when the acute inflammatory process subsides and radicular pain gradually subsides. So smaller discs actually resolve faster. But actually, if you look at the percentage of patients with both sides coming or responding to conservative treatment, it is almost the same. So here you can see that in the presence of a large disc, 80% of patients had major improvements after 6 weeks, and they all attained 90% attained normalcy, which is the same as smaller discs. And there is another paper which shows that a trial of 3 weeks did not cause any problem in this large disc, and you should adopt a conservative problem. Large discs also resolve better because they are absorbed by the body much faster than smaller contained discs. And so the conclusion for this in this important paper is, contrary to popular opinion, the size of a disc herniation should not alter your judgment or your normal pathway where you do a conservative therapy for both of these. The size of the disc cannot be used reliably as a criteria for surgery. Now, if you see a migration of the disc, is that relevant? Now you can see there is a very large upward migration of the disc and there is a very large downward migration of the disc. What does it matter? Now, in my experience, we always find that when these people present, they have more pain and more acute pain and more long-lasting pain than a small contained disc. These discs, when they migrate down, can also trap other nerves one level higher or lower, and so you have to be careful about the level of neurology when you get it. Apart from this, you also found that upward migrated discs always protrude lateral to the nerve root, and this is very important when you operate. You can see that this is an upward migrated disc. The nerve root is actually over here. So you will always find that they protrude lateral to the nerve root, and you can actually go and remove it and easily retract the nerve root medially, and you can get the disc easily out. But when you have a downward migrated disc, it always protrudes through the axilla. And when you have a large protrusion through the axilla, you can see that this nerve root is already battered. It looks completely contused. And you have to carefully remove these discs through the axilla. If you try to take the nerve root beyond the disc, sometimes you will find that it is not only impossible, but you also create a lot of injury to the nerve. So downward migrated discs, you may have to operate through the axilla. Upward migrated discs are easily taken out through the shoulder. And when you have these very large discs like this, it also shows that there may be many fragments and you have to be careful about it. Now you can see that there is a large fragment coming out. Now you may think that this is the only large fragment, but large extruded disc, you can always find that even after you have removed these large fragment, one more fragment or two more fragments be there. And whenever you're operating on this, be very careful that you have removed all the fragments. You must spend some time to make sure that every part of the disc has been removed. Location of a disc, does that matter when you see it? Now, what does it matter when you have a very large centrally placed disc? Now, especially if they occur at a higher level, even though they may not present with a neurological deficit, these are the patients who are prone for a cardio-equina, and you must be carefully following them. These patients can also present with a contralateral SLR, and you must be careful to follow these patients carefully. Third important thing with large discs, central discs, are they frequently get calcified very easily. So when you operate on them late, they prove to have a lot of surgical difficulties. Paramedian discs are wonderful. They are the usual presenting. They have the typical clinical and they are easy to operate. And usually a unilateral approach is very easy. And when you have a foraminal and a far lateral disc, as over here, you have to be careful that you cannot do an interlaminar approach. You have to come through, you cannot do over here. You have to go through the transverse process, intertransverse process at this approach and then this. So this is the importance of this. So what does a black disc mean? Now, this is certainly a major enigma because many of the patients who have a black disc, you see them with a lot of pain, but you don't know that this is the cause of pain. Now, even with the discogram, you cannot be very sure that these are exactly the cause of pain, but you very well know that the loss of signal intensity is due to a decrease in water and proteoglycan content and increase in collagen disc. So these patients must be carefully seen because they are completely different from an aging disc because they have multiple annular tats are present usually there, and it is also documented that people with black disc had a higher prevalence of LBP compared to those with gray or normal discs. Similarly is the other MRI finding of a hyperintensity zone. A hyperintensity zone, as you see over here, and in the axial view, it may be in the center or it may be near the foramen or it may be even in the far lateral. It is usually in patients who have an acute precipitation of an acute low back pain. And this is due to microtrauma. There is an annular tab which enlarges, and every time it enlarges, it has an inflammatory response. And this is not only due to edema, but over a period of time, it undergoes mucinous degeneration of the annulus. And so once you get a HIZ, it doesn't mean that it will go off when it is chronic. Even when there is no pain, it persists for many, many years because it has undergone a mucinous degeneration. So in the imaging, when you see a disc prolapse, what else matters and what else is relevant? Now, some of the things that can be confusing to you is you have a disc on one side. For example, in this patient, the disc is paramedian on the left side, but the radicular pain is on the right side. So how do you deal with this? There are two important papers which have exactly dealt with this. I'm sure that all of us see this from time to time. If the patient does not respond to conservative therapy, if they have a typical radicular symptom, if they have a nerve stretch syndrome, then people do not know exact reason, but the fact that the most patients were relieved by surgery. So surgery can be done in these patients. The herniated disc should be surgically approached through the side of the compression according to the imaging studies and not through the symptomatic side. This is very important. If you want, or if you are not comfortable, you can decompress on both sides, but you have to definitely remove the disc on the side where by imaging it shows that there is a restriction. Especially if you're looking at it in the thoracic spine, it is much more important over here. Now, what you do about a unilateral radiculopathy, but MRI shows contralateral disc herniation, because this is one of the patients where we actually removed the disc and the patient had an excellent recovery. The other syndrome is that you have a bilateral compression, but the patient has only unilateral symptom. So can you do a micro-discectomy on one side? In my judgment and in my experience, I would think that even though the patient has a problem on only one side, if you see on the imaging study that there is a bilateral compression, it would be much better to go through midline and do a bilateral decompression. Because if the patient presents with pain on the contralateral side, and that may be any time, it may be immediately after surgery or after 1 week, after 1 month, or after 1 year, from the point of view of the patient, he will think it's a failed back syndrome. And so it is better that you do a bilateral decompression. What about a facetal cyst, and what does it mean to you, and how is it relevant? Now, if there is no major disc, and if all that you see is a large facet cyst, now you can either operate and decompress, or just as in the case as you see over here, it can also be, if you have a good radiologist, you can do a needle puncture. The needle can be placed exactly in the facetal joint, and then you can put pressure, and then you can break the cyst as you can see over here, and that relieves the pressure quite a lot. But you need a skilled person for that. Now, when you see large midline discs over a chronic period of time, and if you see hibernation of bone over here, please make sure that you also do a CT or carefully visualize in the plain radiographs, because then you will see that there is a lot of calcification of the annulus. And if the annulus is calcified, then you need a different technique, or you may need to excise the whole annulus, calcified mass, and then you may need to do a TLIF. When again you look at a large disc like this, do not just look at the disc, but also carefully look at the margins. And if you see some hibernation over there, or if you see a modic type of change, a signal intensity increase at the superior posterior corner, then you know that this is not just a disc protrusion, but you can see these small whitish things seen over here actually represent a bone avulsion. So this is one of the important causes, and in one of our studies, we found up to 48 to 68% of patients can have a bone avulsion over here. You can see that the disc has come out, but the bone is also avulsed. We are not really sure whether there is a difference in the natural history between these two, but you have to be aware, because when you remove, there will be a lot of bone and end plate coming over here. The last is the new kid on the block, something which is attracting a lot of attention, both in imaging and also clinically, is when you have a disc prolapse, but you also have a large concomitant modic change over here. Previously, modic changes were thought it was due to trauma, and it was thought that this trauma is the cause for this modic change and also for this disc. But now it is completely changing because modic described three different types, and we also know that there can be a mixed modic change in most of these patients. But in most of these patients, you can find that there is good documentation that patients with modic change were at increased risk for severe low back pain. Their level of back pain and their intensity is much more than patients who don't have modic change. They also have back pain at greater frequency, and for each of these frequency, they have a longer duration of low back pain. And what is interesting also is that spontaneous resorption of lumbar disc herniation is less likely when modic changes are present. So when you have a modic change along with the disc prolapse, you need to know that you are dealing with a different kind of patients. And in our own study, which was published in the European Spine Journal, we showed that even when you operate on these patients over a period of the entire 1 year, these patients have more pain and more discomfort than patients who don't have modic change. And you can see that the ODI at pre-op, 1 year post-op is significantly different between the modic and non-modic change. So you will have to know that when modic changes are present, beware, because they are patients who have more painful lesions. They respond to conservative therapy less. There is more inflammation in the biochemistry, and there is a lot of suspicion that this can be due to an infective lesion. And these patients have higher chances of postoperative surgical site infection, and surgical outcomes are not as good as those without modic change. So when you look at an imaging, do not just look at the disc, but look at the all these aspects that we discussed before. But even before imaging, you need to see the patient first and see him as a whole, and imaging then will play an important and crucial role. So thank you very much for this. And then if there are any discussion points from the faculty members, we can have it. Ayush, anything?
Yes, sir. Just a small question, sir. Normally we all have started doing a screening MRI along with lumbar MRI. And what if we see some patient who are classically come with a and your findings are matching, but at the same time you significant compressive myelopathy without these symptoms. How do you go these patients, sir?
So you're saying that the patient has a good clinical radiological correlation for his lumbar spine symptoms, but you have an associated myelopathy on the MRI, which is not symptomatic.
Exactly. Significant myelopathy, which we feel like there should have be symptomatic, but clinically there are no symptoms.
Exactly. Okay. Let me tell you what I did just day before yesterday. So we had a patient who had 4-level severe lumbar canal stenosis with instability, who required at least a surgery which would last for 2.5 hours. No myelopathy symptoms, but he has a multi-level cervical myelopathy, quite severe. And it was very difficult to say whether it is symptomatic or not symptomatic at the lower lumbar level, lower limb level, but obvious myelopathy hand signs were not present. In this patient, I found it too difficult to place him prone and to do lumbar surgery for 3 hours. And I'm not very sure that we would be hurting his, whether we will not be hurting his cervical spinal cord. And so I had a lengthy discussion with the family, and I did the cervical spine first. And next week, I'm going to do the lumbar spine. This is one end of the spectrum. The other end is if you have minor small bulges in the cervical spine, but no obvious clinical symptoms, no major signal changes in the cervical spine, I would still just go ahead and do the lumbar spine, but I'll be careful to have an intraoperative spinal cord monitoring. Make sure that your monitors signals don't change on induction, on positioning, and through the entire surgery. This signal monitoring is not important for me for the lumbar side, but I just want to be sure that nothing is happening at the cervical spine.
Thank you, sir. Thank you for the inputs.
Yeah. Rishi or Naresh, anything on imaging that you want to say? Janardhana, I know you do a lot of imaging research.
Sir, I would like to ask one thing here about the importance of CT scan, especially in the elderly people with the multiple level lumbar canal stenosis. The CT has a role in understanding the levels of compression or the pathology.
CT for me, it doesn't change my decision on which levels I'll operate and whether I will instrument or not. But it will give you a very good three-dimensional idea of the canal and how much of facetectomy you need to do, what you need to do, and whether that means some of these patients have a huge osteophytes above and below, very close to the foramen. So you're already prepared mentally on what kind of surgery you're going to do, where you're going to do facetectomy, and where you're also going to do this, excise this osteophytes. One area where I have found now CT very useful is in modic change, because MRI doesn't show so much of bone erosion, but you do a CT, it shows a terrible amount of bone erosion. And then you know that these patients actually require a fusion at that level.
Thank you. In my practice also, actually recently compared to my earlier institute, here I'm seeing a lot of patients with ligament ossification, especially the ossified ligamentum flavum. We are getting patients coming from fluorosis areas, and I think I'm getting it routinely done nowadays, and I see a lot of ligamentum flavum ossification. So any thoughts on that?
Yeah, if you have a doubt, I mean, Ajoy and Rishi would agree, our usage of CT has gone up in the way of evaluation. At least I have started using CT more and more. And what makes this possible is that the high-end CT machines that you have, we have an MOU, and that allows you to take CT at a very low radiation. Previously, we were always worried about radiation. But now you can take CT of the lumbar spine at, I'm not sure, they said some 6 chest x-rays or 4 lateral lumbar spine pictures. That's all the radiation they say. So when your radiation worry is out of your mind, then CT
Yes.
does give you a tremendous amount of information. One of the other things that CT gives and which MRI doesn't give a lot is your vacuum sign. You can see a lot of gas formation in the disc in CT, but which you cannot identify it in the MRI, and then you know that this disc is completely gone. These patients require a TLIF. Okay. Anything else? Otherwise, I would invite Rishi for the most important talk on conservative treatment and how to bypass surgery with a needle. Yeah, Rishi.
Yes. Good evening, everyone. So it's a pleasure to talk to you about an algorithmic approach to lumbar disc herniation. What are the principles of conservative treatment? And to start with, conservative treatment is the gold standard treatment for lumbar disc herniation. So if you go through the literature, almost 75 to 90% of sciatica patients which happen due to lumbar disc herniation, they resolve very well with conservative measures. And the good news about conservative treatment is it doesn't need any special skills to treat the patients. It's easy to prescribe the set of medications and specific instructions that needs to be followed by the particular patient. And all these treatment modalities have a low risk of complications as well. So what makes conservative treatment successful in patients with lumbar disc herniation? There are 2 important factors. The first one, as we already discussed, almost up to 82% of herniated discs are spontaneously absorbed by the human body over a period of time. And the majority of the initial severe pain which the patient presents to us is because of inflammatory mechanisms. So only in the early phase, the pain is very excruciating. And if we can able to take care of that inflammatory pain, then the patient's conservative management becomes successful. So there are few contraindications if the patient presents with a neurological deficit, or if the neurological deficit is a progressive one, then we have to prescribe surgical intervention, and patients who present with features of a Cauda-Equina syndrome. There is one relative indication wherein patients who have symptoms more than 4 to 6 weeks, despite an adequate period of conservative treatment and with significant disability, again, conservative treatment cannot be continued, because there are some recent literature which shows that a longer period of pain sustaining in the patient, those patients are likely to have long-standing pain even if they opt for surgical treatment later on after like 2 to 3 months time. So what are the different conservative modalities available? The first one will obviously be rest. So there is no definite prescription of how to follow that rest, but usually the patient is allowed to take care of his personal hygiene, and the rest of the time he is advised to be confined to the bed. And but the studies have shown that a period of rest longer than 3 days is not good for the paraspinal muscles. Second is traction, either an intermittent or continuous pelvic traction can be prescribed. Third is varying modalities of physical therapy and manipulative treatment given by a qualified spinal physiotherapist. Varying combination of non-steroidal anti-inflammatory drugs can be given. Neurotropic agents form a main pillar in the treatment of conservative treatment, ranging from pregabalin, gabapentin to amitriptyline. This can be given in various combinations to alleviate the radicular pain. And finally, oral or intravenous steroids can also be used. But these are all practical, experience-based evidence. Whereas if we go through the literature, the grade of recommendation for the prescription of these modalities as part of conservative treatment is very inadequate evidence. So why such inconclusive evidence, even though we find that practically these patients do very well with one of these conservative measures, is that most of these studies have a heterogeneous set of population, because there will be ethical considerations to treat one set of patients without any treatment and other set alone to have a type of conservative treatment. Again, for the same reason, high quality randomized controlled trials are not possible to apply in patients with lumbar disc herniation. And the third one is the treatment failures are less. So if you treat 100 patients with lumbar disc herniation, almost 90 are going to recover, and only 10 will have a failure of conservative treatment. And again, it is a pain-based assessment. So patients respond to pain in a widely variable manner. So it is difficult to have a standardized output. So that's why different surgeons follow their own experience-based medicine as a cocktail for treating patients with lumbar disc herniation. Then there is one thing which has been of proven benefit even in literature is epidural steroid injections, specifically a contrast-enhanced fluoroscopy-guided nerve root blocks, which has been found to have high quality, sufficient evidence to be prescribed in patients with acute disc herniation. So the reason why local steroids, which are given specifically over the nerve root, are effective is that, as we all know, that radiculopathy is caused by both nerve compression as well as by inflammation. But the initial acute inflammatory pain is because of autoimmune response to the disc material. And if we can be able to take care of that inflammation, then the patient's pain is relieved very much. So there are different modalities through which we can administer these steroid into the epidural space: caudal, interlaminar, or the transforaminal route. The same steroid drug is given, but through 3 different routes. But the key difference is that transforaminal epidural steroid, also called as the selective nerve root blocks, are very effective because they are very highly specific, and it is given directly over the inflamed nerve root. So the entire drug is given in a concentrated manner over the inflamed nerve root. That's why it is advised in patients with acute disc herniation. So it is the popular and standard of care in Western countries, and it is becoming popular in India as well. It's an hour care procedure where patient has the injection and goes home within an hour. It has immediate analgesic effects. The patient comes with excruciating pain, and along with the steroid, you have some bupivacaine also in the cocktail. The radicular pain is immediately relieved for the patient, given under local anesthesia, and the medicines are also quite cheap. And the common question which people ask is which nerve root to target. So usually the most common type of herniation we see is the posterolateral disc herniation. So for example, if there is a patient who has an L4-5 right side posterolateral herniation, the L5 nerve root, that is the traversing nerve root, is affected. Hence, we have to block the nerve root below the L5 pedicle. So L4-5 disc, L5 nerve root, go below the L5 pedicle. So that's the standard dictum which we need to follow. So assume that this patient is having an L4-5 disc. So the green color indicates the nerve root, which is hidden behind the lamina or the pars region where the nerve root is getting compressed. So when we have to give the injection, we have to go below this region, below this pars of particular bone called the pars, where the nerve root is covered by the bone. Hence, we have to follow as oblique view of the spine. So the first step which we need to follow to give a nerve root block is to get an oblique view of the spine so that the nerve root is uncovered from the pars. So that's the oblique view. So we have to go below the neck of the dog to give the injection. So in this patient, the patient is having a right L4-5 disc prolapse. So that's a Scotty dog. And I have placed that spinal needle close towards the neck of the dog. I confirm the position in the lateral view where it is just below the pedicle and in the center of the nerve root foramen. Then the dye is injected to confirm the position. And once this is done, the final injection is given. So now I will show a small video. So this patient is having a L4-5 disc prolapse and the predominant symptoms on one side. So as we can see, this is a schematic picture. So this is the pedicle and this is the nerve root, and this part of the nerve root is hidden below the pars region. So we have to get a oblique view like this so that we can target the affected nerve root clearly. So this is the Scotty dog view. So first is the local anesthetic to infiltrate the skin. Second is the dye, which we need to visualize the nerve root. And third is the combination of the final drug, the steroid with the bupivacaine. So the patient is awake and placed in prone position and under image guidance. First thing is to get a parallel view of the end plates. So cephalocaudal tilt. Next is to get an oblique view to look at the Scotty dog appearance. So I have placed a needle over the skin of the patient to help myself to go under the pars region. So next is I infiltrate the skins and the fascia so that the patient cooperates through the procedure. And then I place a spinal needle. So the spinal needle is directed in line with the C-arm. So if it is directed in line with the C-arm, so automatically it will go below the pars closer towards the traversing nerve root, exiting nerve root. Right, so now the needle has been directed underneath the pars region. Once I have passed the needle to a reasonable extent, I get a lateral view to see whether I am inside the nerve root foramen. Then I confirm the position by giving the dye. So the dye is an iohexol, which is a standard dye available. And if the needle is in the proper position, so you get a good radiculogram. The dye spreads along the course of the nerve roots, indicating the correct position of the needle. So once this is confirmed, then we give the final injection, which will be triamcinolone, 80 milligram of triamcinolone along with bupivacaine. So what is a post-injection protocol? The patient can walk within 30 minutes and go home within 1 to 2 hours. Some patients can have numbness and subtle weakness because of the bupivacaine, but usually it reverses within 4 hours and they can get back to their normal work within from the next day. So which nerve root to inject? Like I told, if it is a posterolateral disc herniation, target the traversing nerve root. If it is a foraminal or a far lateral disc, target the exiting nerve root. And if it is a posterocentral disc, ask the patient whichever side is more symptomatic and then block the traversing nerve root. Sometimes patients present with unilateral 2-level disc herniation, can we inject 2 nerve roots? Yes, of course, we can inject 2 nerve roots. So this is a patient who had a 2-level disc herniation, L4-5. Then we have blocked both the nerve roots. So how frequently can we inject? For correctly chosen positions, it has a very good success percentage. So we did our study and found that 75% of patients escaped a spine surgery. And if the pain recurs after 6 weeks, a repeat injection can be given. But if there is no relief even at 1 week after giving the injection, or if the pain recurs within a period of 6 weeks, then better to go for a surgical intervention. So the S1 nerve root is a tricky one. So the technique which we described above is for all nerve roots starting from L5 up to L2. Whereas for the S1 nerve root, the S1 nerve root is concealed by the sacral lamina completely. So you have to target the S1 nerve root through the first sacral foramina. Right, that's the one. So this is again a small video. So her patient is having a right side L5S1 disc herniation. So I'll skip this part and I'll go straight away to the Shyam picture. So here we don't get a oblique view. So we just get a good cephalocaudal tilt. The Shyam has to be tilted as if we are getting an inlet view of the pelvis, till we see the sacral foramina clearly. So these are the sacral foramina, the right and the left side. It should be seen like a cat's eye. So if we are able to see this one clearly, then that's the correct position of the Shyam. And then again, if we follow the same thing, so we inject the skin with local anesthetic, then place the spinal needle. So this is the local anesthetic injected a small hypodermic needle. Then we pass the spinal needle through the skin. So the needle is just inferior to the foramen. So I have to guide it a little bit cephalad. So yeah, now it is going inside the proper direction. So if I can go through the foramen with a small giveaway sensation, then I get a lateral image. And in the lateral image, it should be in the sacral canal. So here it is inside the sacral canal. So that indicates the position is good. At this moment, we get an AP view again and then inject the dye. And if the dye confirms the position of the right S1 nerve root, then the final drug is given. So we did a study, as I told earlier. So we recruited 91 patients, and out of which who were followed for 1 year, 69 of them, which meant 75% success with the selective nerve root block. 22 patients failed to have good relief and required a surgery. And the important prognostic factors which we found were increased sensory symptoms preoperatively, patient who had a higher disability, patient who were in a white-collar job, presence of a lumbosacral transitional segment at the level of the disc herniation, and a splash pattern of radiculogram. So we found 4 different types of radiculogram and we injected the dye. The one which we had a splash pattern indicated a poor outcome. So the take-home message is conservative treatment is the gold standard treatment for patients with disc herniation, and it is quite highly successful. So there are different modalities through which we can treat a patient, and based on your experience, you can formulate your own protocol. And highly effective are these selective nerve root blocks. They are very effective in the acute stages, especially in unilateral radiculopathies. And it has a very short learning curve, and it is very less complicated and has very good outcomes. Thank you.
Can I make a quick comment, Rishi?
Yeah,
Please,
Yeah.
please.
Yeah. So we also have a very good experience with selective nerve root block, and we European Spine we published in 2015 on selective nerve root block, and some of the findings are similar to you, but there's few subtle differences. What we found that 1/3 of the patient we had a complete relief, and 1/3 there was a partial relief. 1/3 they didn't had any relief. So and in patients where we had a partial relief and we operated, they did much better than those we didn't had a complete. We have no relief at all. Something we published and just wanted to just add to your findings.
So Ayush, that is interesting because I tell my patients the same, because they keep on asking what is the guarantee, what is the percentage success and all that. So I tell them, okay, if you are lucky, I also put the figure at 40%, you will escape surgery. 30% you will be partial and you can go on for some more time, but that will give me a good indication that this pain is exactly coming from this problem, and I am more confident of giving you a good result after surgery. And this is actually important part for me in the injection. So that is absolutely true. Anything else on injection? Rishi, how often can you give this? Because that's another thing.
So,
Which
Dr. Rishi, it was a nice demonstration. Just I wanted to know the type of disc herniation, the disc bulge, protrusion or extrusion. Does it have a bearing on the effectiveness of the transforaminal steroid injection?
Yeah. So, sir asked a question. I would like to answer sir's question first. So, sir asked how frequently can these injections be given? So, the first, I had highlighted this in the presentation as well. So, if the patient doesn't get any relief at all from the root block, even though if you get a good radiculogram, and I don't think there is no point in pursuing with the conservative treatment like giving a root block again. And there is a second group of patients who have a very good relief and they get back to their normal activities, and then they come back with pain either within like 3 to 6 months time. And in that instance, we can give the root block again if the new MRI doesn't show a fresh problem. And if the patient has very good relief and again comes later on, like 1 or 2 years later, then again a root block can be given. And coming to your question, we did this analysis also in that study. We found that patient who had a sequestrated disc responded very well to root blocks, whereas those discs which are contained within the annulus, so where we find the mechanical compression is more severe compared to the inflammatory part. So in those situations also, we find that it doesn't work very well.
okay.
Naresh,
Yes.
you give your blocks with the not in the oblique view. Therefore,
I use this technique extensively. So, root blocks is one of the main workhorse in my practice, and I'm quite happy with the way they work. And especially the ideal candidates are the elderly ladies with multiple level stenosis with one radicular pain, which they come with severe pain. And if you see the MRI, it's like a degenerative scoli. You want to do full work, they simply get relieved with a small root block or the selector nerve. But what I do is, because I keep teaching a lot of fellows, so to be on the safer side, I don't use this oblique view. I try to give it extra foraminal AP view. Use that tactile feeling of slipping on the side of the pars while putting the needle between the transverse process and pars junction. And then you can nicely feel that your needle is tilting into the foramen. And then if the patient gets relief with the xylocaine, then we'll give the dye. This is on the safer side, not to pierce the nerve, because the initial description when we started doing this is to pinch the nerve, elicit the pain, and then give the xylocaine. So that practice we stopped doing. So this really works. But the only problem with this one is this can spread across the 2-3 nerve roots. When you're using it for a diagnostic purpose, you may have issues with this technique.
I think this is what recently the anesthetists are practicing is at like an erector spinal block. So,
Yeah.
something like that.
Yeah. So we are actually using the erector spinal block very widely. I mean, it's quite good. I mean, it's all on the same principle for this. Okay. So we just go on to the next talk. So there is a tip for success in disc surgery and also the steps of micro-discectomy. So I thought I'll start off with my this slide. I keep using it all the time, because disc surgery is the most commonly performed surgery. And for every surgeon, if you ask, they can get back into their memory. They'll always remember where some of their disc surgery patients have been very, very unhappy for some unknown reason. So that's why I always say surgical outcome can be terribly simple or simply terrible. And if you have to get it right, I think the first and foremost important point is to operate on the right patient. I mean, if you ask me, there is only one thing that's most important, then it's choosing the right patient. Not everyone in the disc with disc in the MRI needs surgery. That's number one point. And don't bypass conservative treatment. Now, at the end of it, if you get the clinical radiological correlation, which we talked about, Now, if you made a clinical judgment of a L4-5 disc with L5 nerve root symptom on the right side, and this again is corroborated by the MRI, then you can be sure of a big level of success. But if there is some discrepancy in this, either in the level or in the side or in the type of pathology that you think, then there is a chance that your success rate may go down. So be very, very careful. So what surgery you do doesn't matter whether you do a fenestration or endoscopy or microscopy. It doesn't matter so much as to which patient you are operating. And we know that failures in this surgery is not because whether you used endoscopy or micro-discectomy. It's very often due to choosing the wrong patient, wrong timing of intervention, wrong level and wrong side. These are all the major causes for mistake. So all the tips, I would just go ahead now with taking this through the
chances
video,
for
and I'm going to
post-discectomy
demonstrate
fibrosis is grossly reduced.
ligament flap technique. And this is in a 38-year-old male with low back pain. Classic failed conservative treatment, right-sided list with a positive SLR 50 degrees. And very importantly, just don't look only at the MRI, but also make sure that you look at the plain X-rays. Make sure there is no congenital abnormalities over here. Make sure the interforaminal space is quite good. There is no rotation and there is no instability in the spine. These are all very important. And then you look at the MRI, and here you can see very carefully whether the bulge is at the same level. You can see that there is a connotation of there being inferior migration. This is very important because if you're doing a micro-discectomy, your view is only limited over here. And if you're not aware that there is an inferiorly migrated segment, then you might miss that. And that can be a major problem. So you look at both in the sagittal and in the coronal view of what is the fragment and where it is. And that is very, very important to do. Now, the steps of the flap technique is we'll come to over here. Now, what is most important is that positioning is very important. From time to time, you can get into a problem if you have not positioned properly. Now, foremost is the head. Be very, very careful for the eyes. There is a variable incidence of eye problems and blindness in spine surgery. And make sure you are not hyperabducting over here. Abdomen must be absolutely free. There should be sandbags beneath the ASIS. So you should see that the abdomen is quite free over here and make sure that the pressure points are all well padded. So if you do that, then it is the right time to start the surgery. Level marking under Shyam is extremely important. The more you do a minimally invasive surgery, the chances for you to miss the levels is very high. And this must be done by placing a needle, which is 2 centimeter lateral to the midline. And we confirm the levels at 2 points of time. One is before you start the skin incision. Make sure that the needle is in the same direction of the disc. Make sure that the needle is not coming like this or coming like that, but it should be in the same angle of the disc and mark a 1 centimeter incision over there. And then you should make the dissection in the same angle. That's very important. So once you have marked the, then what you do is you go by a central incision and you elevate the flap over here and you start off from the midline. You take the whole flap, you use a 15 blade knife, be very careful. And then you elevate a flap which is attached to the lateral side. You tuck the flap underneath the muscles and then you will get exposure of your nerve root. And once you have finished, you can put the flap back in position. And that will completely dissolve this problem of scarring. Scarring happens when there is a tissue loss. And when you can put your native tissue back, you have a possibility that there is very less scarring. Now, as in all the other cases, it's important that you place the position carefully. Oh, okay. Now, I will just go on to the recorded voice over here.
Process is released with a corpse elevator and the use of diathermy. Because the incision is very small, and when you use the diathermy, we have to be careful that the diathermy tip does not touch the
Clear, sir.
or the corpse elevator to avoid a diathermy burn of the skin. So once the muscle has been elevated by the use of the corp elevator, we then come to the stage of introducing the Michellos retractor. The Michellos retractor has a muzzle blade which is broad and also a thin blade which is placed medially in the interspinous area. And then the retractor is loaded onto these blades, and then a distraction can be done so that the interlaminar space is clearly visible. So here you can see that the Michellos retractor is in position, and there is an incision of about 3/4 of an inch. The placement of the Michellos retractor is crucial. You can see that it has two different kinds of blades. Medial one, which is sharp, and the lateral one, which is blunt and broad, which retracts the muscle. The medial one goes on the medial side between the two spinous processes. If you consider here the two fingers as the spinous process, you place this retractor on the interspinous ligament. And then you use the broad muzzle retractor laterally to retract the paraspinal muscle. Once the interlaminar space has been reached, it is important that we do the level check for the second time. This is very crucial, especially in a patient who is very obese. Even though the incision on the skin could have been placed correctly, if there is an approach that actually angulates even by 10 degrees, we can reach a level which is either caudal or cranial to the disc space that we need to reach. So once we reach the interlaminar space and S1, once you reach the space, here we can see the anatomy. Okay, now you can see here that this is the orientation, medial side. Okay, you can see that the sharp retractor is here. Lateral side, you can see the blunt and broad flange here. Cranial, this is the lamina of L5. And the caudal, this is somewhere the sacrum is over here. Now the facet joint is somewhere makes micro-discectomy much superior to other forms of discectomy, because we are trying to preserve the ligament of flavum, which you cannot do by endoscopy or by any other method. When you use your knife is very little. If the ligament of flavum is very loose, then you actually need to cut it by using your knife, and that is not very good. So take a 15 blade knife, not an 11 blade knife, and then you go to the midline and then make a small nick. Okay? You see, I'm going layer by layer. There's no need to hurry on this. So we are going close. So we have gone through a few layers. Now if you see here, there is a small change in color at the bottom, which means you are on the lowest layer of your ligament of flavum, and then you don't go further with your sharp instrument, but you use a blunt probe to get it sorted out, okay? And then just in case there is some fibrosis, I would just make sure that there's nothing. And then you have a choice. You have a choice to now remove the ligament of flavum using the knife again. Make sure that the tip of the knife is always under your vision. Huh? But this is a safer way. You just put it at 1 or 2 millimeter, and then you bite close to the attachment. Can you see? Always look at the deeper layer of the ligament flavum. I can see the lower part of the ligament of flavum. If you are not able to see this cleavage, you should not bite. So I'm seeing till the very end. And this is the flap. So we have done the flap on the superior side. I'll go ahead to do the flap on the inferior side. So that is a flap. And little more. This is really a trick because if you do it more, it comes off in your hand. So you need to give a sustained pressure for about. One of the important thing is at the L5S1, you should not see the nerve root so clearly immediately. If ever you see the nerve root so clearly, and the nerve root is also on the same plane as the main dura, then you know there is something very huge which is pushing the nerve root superiorly. Yes. Okay? Yeah. So I will show you once we remove. So this is the lateral border of the nerve root. This is one important anatomical landmark. If you don't see the lateral border of the nerve root, you should not proceed further. So you can see the lateral border here. Yeah. And then I use this to gently retract. Okay?
Big epidurals.
There are always big epidurals. Whenever you demonstrate, I don't know where these epidurals will come from, but they come. Yeah, it's all right. Now you know the reason why there was so much of inflammation, because you have raw disc underneath. And that is the reason there was there. Now this is the lamina. At L5S1 level, the disc space is usually here, but you see the whole of the disc is much inferior. So this is an inferiorly migrated disc. I will gently try to take it out. Suck, please. Whenever you remove a big fragment, then that is the case where there might be another fragment. So never be satisfied when you get a big fragment outside, because nothing prevents another fragment sitting there. So you put your probe and try to get all the fragments outside. Okay, you can see that we are trying to get another fragment is coming out. Yes. Wow, yeah. So that is the lesson. So when you have a big fragment coming out, always think there is another fragment sitting there. Okay. And when you remove the second fragment, the lesson is that people who have the second fragment always have the third fragment cavity there. Okay. There's another one coming up here. So right. So that's called the spinal episiotomy. Makes the delivery very easy. And then you go and remove the rest of the disc. So we have already almost removed everything, but I feel happy if I do this. There are lots of people who put in a big catheter and give a wash. I don't do that. I just, yeah, okay. Now you can see inside the disc space and coming out like that. Okay. So this is something very important to learn. Now, the whole work is finished. We haven't fortunately disturbed any of the fiery epidural veins there. I would just go in and then probe again. Superiorly, it's fine. Inferiorly, it's very loose, no problem. And then we call the nerve root mobility test. So I would get the main dura, look at that. Yes. Can you see the nerve root? It's so mobile. I am just putting a very little pressure and it is nicely mobile. I normally don't keep my retractor on the lateral side and retract that dura. I usually keep it on the main dura and pull it to make sure that it is easily mobile, and that is it. Excellent. Now this is the epidural veins. There's no need to touch any of these. And the whole width through which we have operated is, I'm just showing a 4 millimeter upcutter, and you can see here it's only the amount of ligamentum flavum I have removed is just on the footprint of a 4 millimeter upcutter.
So once you do that, you can actually place back your ligamentum flavum flap, and that actually settles down. There is no need to stitch your flap, and it will stay in position. And then you do a typical closure. You need 1 or 2 stitches on the muscle and 1 or 2 stitches on the fascia and a few stitches on the skin. So the most important thing is to get it right the first time and make sure that this patient actually required the surgery. You have passed through the conservative treatment and the patient actually asks for the surgery, and then you will do it at the right level on the right side and without injuring the nerve root and without leaving a hematoma behind, and then the patient will have good results. Okay, anything else anybody wants to add on the micro-discectomy technique? I think the points are actually looking at the level correctly, not hyper handling the nerve root. If you have a large disc coming down, you should learn to operate through the axilla without injuring the nerve root. Superior migrating discs are through the shoulder, and don't leave a big hematoma over there. Ayush, anything? Siddharth, you joined late. Anything you want to add?
Flap technique, on the 2 times that I have tried it, I have managed to remove the flap on the last bite where you feel that little more to tuck it in, and both times the flap broke in my hand and then I had to abandon the flap technique. I think that part is the tricky one, to not resect enough to get it out in your hand and just resect enough that you can actually still retain it and reposit it. I think it works best for L5S1 where you have a larger interlaminar space. Sometimes at 4-5, it's better to just do a partial, maybe a small laminotomy to just aid the process.
Definitely. It certainly is not for high level discs. And also the L4-5, you need to be very well experienced to do that. L5S1, it's easy to do.
I've been trying for a long time, but never successful. So
Naresh, you are operating too many cases and you are in a hurry.
it solely happens with the boss hands.
Another thing is, I think you need the RH frame to do it. If you put it on bolsters, it's again very difficult because the interlaminar space closes a bit also. If you have a Relton Hall frame, it works better.
Do you practice this if there is a severe stenosis also, sir? There is a hypertrophied ligamentum. So
if there is a stenosis, then the thickness of the ligamentum flavum will not allow it to come out as a flap. And there, your aim is also to do a flavectomy, so that's a part of your surgery. So you don't want to put a hypertrophied ligament. But the only big advantage of this technique is because in endoscopy, sometimes you need to take a little bit of bone if you have to go this thing if necessary, sometimes. But here in micro-discectomy, you don't need to touch the facet joint. You're well away from the facet joints when you operate. And then the chance to address all other issues like hypertrophied ligament or osteophytes or foraminal stenosis. Every other pathology there can also be completely addressed. So, I mean, it's the trick which you have learned for a long time, and then I'm sure if you ask Rishi or Arvind Kulkarni, they would say endoscopy is best. I think it's what happened. What's in your hand best for that patient. So now we go on to the other popular minimally invasive technique of endoscopic discectomy, and Rishi will demonstrate video on how to do it.
Right. Thank you, sir. So, endoscopic lumbar discectomy, is it the way forward? That's the topic that was that has been given to me. So, if you look at the evolution of how we approached herniated discs, initially it was started with an open laminectomy, which was basically bigger access to reach the herniated disc. Then it transformed to just an open discectomy. Then with the introduction of microscopes, we moved on to micro-discectomy, and micro-discectomy still remains as the gold standard technique to approach a patient with a disc herniation. Then the problems of access were recognized by some tubular surgeons, and tubular surgery was promoted along with microscope. So it was called as the micro-endoscopic discectomies. And endoscopic discectomy of late, with its new armamentarium of high technological cameras, have made endoscopic discectomy as currently one of the smallest access and better result giving procedures for a disc herniation. So success in any spine surgery depends on four things. One is it should relieve the main symptom or the symptoms of the patient for which he has presented to us. And while doing this, we should minimize the damage which we create during accessing the spine. And whatever the technique that is introduced should have less complications, and it should be reproducible across the globe by even the average surgeon. That should be the goal of any technique for any surgery. So if we take a discectomy, so if we compare laminectomy through microdiscectomy to endoscopic discectomy, the main purpose of the surgery to provide a adequate decompression of the nerve root, and how we are going to minimize the damage which we are creating during access it varies widely with the technique. The open laminectomy, it will be wide, whereas an endoscopic discectomy, it is the least. And if you look at the ability to reduce the complications and whether the techniques are reproducible, over the years, it has been shown that all the techniques with adequate experience and practice have a chance to reduce the complications, and they are well reproducible. So endoscopic surgery is the new kid on the block, even though it has been introduced in 1975 by Cambin. Of late, with the introduction of newer technologies and better understanding of the disc herniated related problems, it is currently coming up as the technique of choice for patients with disc herniation. Because the unique selling point of endoscopic surgery, it minimizes tissue trauma. Actually, there is the least minimal tissue trauma to the spine while accessing the disc, because the cannula through which it is operated is only 8 millimeters. And it uses the standard windows which we use for a standard discectomy, the interlaminar approach. And the transforaminal herniation approach also has a very least damage to the paraspinal musculature. It provides a very wide visual field because of its good illumination and magnification. And another important advantage, especially for a transforaminal approach, is that it can be done under local or regional anesthesia. So all the advantages of endoscopic discectomy are mutually beneficial to each other. So it is a smaller incision, less blood loss, lower complication rate. The blood loss and the chance of infection is also much less. The post-operative pain is very minimal. The patients are up and about within 2 hours after the surgery. So their confidence in the procedure and their choice of treatment also is much good. And they are able to return to their activities of daily living much earlier. So how does an endoscope work? So the major workhorse of endoscopic surgery is the video endoscope. So it has 4 holes. So the one is the main working channel, which is about 5 millimeter in diameter, and it has a camera which is a high quality 4D camera. And it has an irrigation channel which continuously pours normal saline into the surgical field, and a bright light source. So the key steps of endoscopic surgery will be to create an ideal entry point. So ideal entry point is one of the most important thing, because we are going to access the spine through this only entry point. We can't extend the incision above, below, medial or lateral as the procedure progresses. So the entry point is the key. Then once the entry point is created, 8 millimeter diameter working cannula is docked either in the interlaminar or transforaminal region. Then once it is docked, we pass that the video endoscope through the channel, through the cannula. And once we are inside the spinal canal, the discectomy is done through standard disc punch forceps and cutters. So there are one difference actually between the transforaminal scope and the interlaminar scope. It is mainly the length of the cannula. For a transforaminal approach, we access through a lateral approach. So we need a longer cannula. Whereas an interlaminar approach, it is a short length cannula. This is the only difference. So rest of the things are the same. The important thing to note is that the camera lens is positioned at an angle of about 25 degrees so that we can have a wide view of the spinal canal once the camera is inside. So how to choose which technique to use in a particular patient? So for most L5-S1 level, interlaminar is the preferred one, because the space is wider. It is easy to enter into the spinal canal. L4-5, if the interlaminar space is reasonably wide, or if part of the facet joint can be burred using endoscopic burr, then again it is a preferred approach. And either it is a posterocentral herniation or lateral herniation, this technique can be used. And since it replicates the standard discectomy, which we are used to be doing regularly previously, so this transition to an interlaminar endoscope is much easier. Whereas the transforaminal approach, it follows a different technique. Actually, it was the initial technique with which the endoscopic techniques actually flourished. It uses the intervertebral foramen as the port through which we are going to enter into the spinal canal. It can be done at all levels. Even a lot of surgeons are using it to do thoracic discectomy as well now. But at L5-S1, because of the iliac crest, we may not be able to use a transforaminal approach. The only thing, it has a learning curve since it is a new exposure for us. And olden days, it started with an inside-out surgery where the initial focus was on removing the disc from inside and rather indirectly decompressing the nerve roots. Now the present focus is on outside in. So where we see the thecal sac, where we see the nerve root, where we see the layers of the deeper layers of the annulus and the disc herniation, and then proceed to doing the discectomy. So my main video will be focusing on the interlaminar approach. So to start with, the first thing one should make sure is that the patient should have an adequate interlaminar space. So you have to see that side of whichever side the patient is having symptoms should be at least 8 millimeters so that we can pass the cannula through the interlaminar space. If you think that the interlaminar space is less, then either we should proceed to a transforaminal approach, or we should be ready to use a burr to remove part of the facet joint so that the cannula can be passed through the ligamentum flavum. So the patient is placed under general anesthesia and radiolucent bolsters. We can't use a radio opaque frame like the Reltal Hall's frame in this situation. The first thing is to check the interlaminar window in the AP view. So a small incision is made. So it is about 8 millimeter in diameter, exactly over the interlaminar space. It is done under the image guidance. And once the incision is made, trocar is passed through the skin, muscle, and the the thoracolumbar fascia through the paraspinal musculature, and it lands at the level of the ligamentum flavum. So this position is confirmed under image. So in the AP view, the tip of the trocar has to be resting on the interlaminar space, and in the lateral view, it should be below the lamina of the L5 vertebra. So once this is confirmed, then we Then we pass the cannula. So this is the cannula, which is about 8 millimeters in diameter, which passes through the trocar. And once it is placed inside, the trocar can be removed. So the trocar is now removed. And then through the same hole, we'll be passing the working video endoscope. So continuous saline irrigation will now be given. So once we reach the operative site at this level, so what we see will be a course of deep, short external rotators of the spine. So you see some muscles which has to be removed. And once it is removed, we have to see the ligamentum flavum. And the next thing is to cut the ligamentum flavum starting from medial to lateral. So somewhere from the midline towards the interlaminar region, towards the lateral part, that is the facet joint, it should be cut. So it is a linear cut and it should not be a irregular cut, so that once the surgery is over, the the cut margins of the ligamentum flavum will be automatically approximating against each other. So once we enter the cut ligamentum flavum, inside we have the important neural structures that needs to be visualized. So we will be seeing the epidural fat. We should be able to see part of the thecal sac covered by the epidural fat. Next, we should be able to see the nerve root, which is getting compressed by the prolapsed disc. And finally, we should be able to see the lateral part of the nerve root. So it is important to see the lateral part of the nerve root, because unlike a micro-discectomy, we can't angulate the microscope and use a nerve root retractor or something to push the nerve root away. So only if you see the lateral part of the nerve root, then it is easier to place the cannula inside and rotate it. So that is a key part of the surgery to be performed next. So like I told, so we visualize the lateral part of the nerve root over the prolapsed disc, and the cannula is docked. So the cannula has a beveled edge and the sharp margin is placed over the lateral part of the nerve root, and then it is rotated about 180 degrees. So this rotating maneuver actually pushes the nerve root medially away from the prolapsed disc, and the prolapsed disc automatically comes inside the view of the surgical field. So this is what we see once the nerve root once the cannula is rotated. So the bulging disc fragment will be coming under the view, and beyond the margins of the cannula will be the nerve root, which will be adequately protected by the cannula. So now we can incise this bulging annulus with the knife or a cutter, and then the disc fragment can be completely removed. And post-discectomy, we should be able to see the nerve root, which is devoid of any pressure. So let me show a representative case. So this is a 55-year-old female. So she has quite a huge disc herniation at the level of L5S1. So her symptoms are on the right side. So I will start from the level where we pass the cannula after the level has been marked. So once we enter into the through the cannula, so this is the first thing we'll be seeing. So there will be a lot of paraspinal muscles and fat. So we use that cutter as well as the radio frequency probe. So I will just orient the surgical field. So the upper part of the circle, so this circle is the total surgical field, which we'll be visualizing. The upper part is the medial side and the lower part is the lateral side. And we are working from the right side. So the nerve root will be coursing somewhere like this, and the disc herniation should be lateral somewhere over here, right? So the two instruments which are commonly used before we enter the ligamentum flavum will be the grasper and the radio frequency probe. So the radio frequency probe is also helps us to cauterize the bleeders as well as to shrink the tissues here. So I'm removing all the fat and muscles which are over the ligamentum flavum, and I use the radio frequency probe to shrink the fat and the muscles. So the yellow bright white structure which we see is the ligamentum flavum. Now it has to be cut using the cutter. So the cutter is an instrument similar to a grasper, but it has a sharp end. So it starts medially and then we proceed laterally as we cut the layers of the ligamentum flavum. So layer by layer, the ligamentum flavum is cut, and now we have entered into the spinal canal at one particular point. Once we have entered from the midline, so slowly we are proceeding laterally towards the deeper layers of the ligamentum flavum. aim is to reach up to the lateral border of the nerve root. So this cutter should be visualized while using it as a cutter, because if it is used blindly, we may be injuring the deeper structure. So we are seeing the bulging nerve root pushed by the prolapsed disc fragment. So I'm using a dissector to gently push it. So we can see it's quite tight. So the nerve root, the disc fragment is quite big. So what we do in a regular discectomies, we do a laminectomy or laminectomy at this stage to see the shoulder of the nerve root. But here what we do is we still go lateral, cutting the deeper layers of the ligamentum flavum. So now I have reached the lateral part, lateral to the nerve root. So now at this stage I will be pushing the cannula, but since it is a huge disc, what I'm using is using a knife to cut the lateral part of the herniated disc, remove part of the disc fragment so that the nerve root will be partially decompressed. Then I will be rotating the cannula inside. So I'm decompressing part of the disc fragment. Right. So now I am rotating the cannula. So once the cannula is rotated, the nerve root is pushed medially by the bevel of the cannula, and whatever bleeders which are present are buzzed using the radio frequency probe. So now we can see as the cannula presses over the annulus, the fragments start coming out. So I'm making the annular cut wider with the use of the cutter. And the fragments are large fragment are removed. So this cannula actually presses against the annulus, that actually makes the fragments to come out of the from the inside of the disc easily. So it's quite a big herniation. So as we keep removing, more fragments come. So the end point of the procedure will be, we don't get any further free fragments from the inside of the spinal canal. And the nerve root should be free. So frequently what we do is we rotate the cannula and then see how free the nerve root has become. And if it is still tighter, so we remove more fragments. So as I rotate the cannula over the disc fragment, more fragments come out. Right. So now after so that shows the nerve root has been completely free. So this is the region where the nerve root has been pushed up and there was a lot of disc fragment which has been removed. So the post-op protocol is the patient can be mobilized within 2 hours and can be discharged on the same day or the next day. And the standard precautions over the next few weeks are followed as per any patient who had a discectomy surgery. The second approach is the transforaminal approach, which uses a posterolateral access to enter the spinal canal. So through the foraminal window, just distal to the exiting nerve root, we reach the spinal canal. Right. So this is used very favorably in foraminal and far lateral disc herniations without any need for a open Wilsey approach. And it can also be used for central and paracentral disc herniations. So the key thing is to identify the Cambine's triangle. So the borders of the Cambine triangle, which you all know, the hypotenuse is the nerve root. So the base of the height is formed by the thecal sac and the traversing nerve root, whereas the base is the superior end plate of the inferior vertebra. So we dock the cannula over here and then try to do the discectomy. So important thing is to place the guide wire. So when we place the guide wire, this is the ideal position. In the AP view, it should be between the pedicles. So it should not cross the medial pedicle line. Whereas in the lateral view, it should be just touching the posternal. So this is the main key thing. Once this is achieved, the working cannula can be placed. And as I told earlier, we currently use the outside-in technique to remove the disc fragment. And the same post-discectomy protocol is followed as for a patient with an interlaminar discectomy. So there is something called Gartner's hype cycle, something similar to a Scott's parabola. So this I took from one of review article by Dr. Roger Hartel. So this is applicable for any new technology or a new technique, either in a technological industry or a medical or a business, wherever there is an innovation, initially there is a trigger and there is a peak of inflated expectations. And as a large group of people starts following it, there will be a trough of disillusionment. And as more and more people find that it has some benefit in the way it works, there will be a slope of enlightenment. And depending upon the efficacy of a procedure, it can remain in the trough or it can come up in the slope of enlightenment. So as per these reviewers, they find that endoscopy has reached the stage of slope of enlightenment, and as more people start using it, its technique can be much more refined, and more people will be able to get the benefit out of it. So in conclusion, endoscopic techniques are becoming popular, and it has some advantages over the open microscopic procedures. And with minimal access, we can provide better outcomes to the patients. Of course, there is a learning curve involved in this. Thank you.
Well, thank you, Rishi. Thank you for all the demonstration, also giving the pulse and tips for the good surgery. Naresh, what is your, between the faculty members, how many of you are for endoscopy and how many have stayed with micro-discectomy?
Recently started using the endoscope, midline endoscope, sir, with a short scope. I think to be accustomed to what we are trying to do is we put a scope now and then do discectomy and then again open it do traditional micro discectomy and check as long as we are happy. Maybe for the initial few cases we're going to do that. What we found out was the case like what you showed, where there is a lot of 3 fragments were coming one after another. We had one case like that, and we were able to remove the initial fragment. We thought it was fully decompressed, and then when we opened, then we saw 2 fragments significantly migrated. If that is the situation, I want to ask Rishi how to tackle the quite inferiorly migrated disc fragments.
So actually that cannula as well as the video camera has nice bevels there. So if you rotate the cannula, we will be able to see up and down at least 1.5 centimeters above, below the disc, lateral part, everything will be able to visualize. And there is a nice curved nerve root probe-like structure, so if you put it under this nerve root and rotate it, any free fragments which are hidden below the thecal sac should be able to come out.
Rishi, how much of
Not able to hear you.
Oh, sir, couldn't hear you, sir.
There is one person giant Galaxy A50.
Galaxy A50 has got a radio or some music going behind. Okay.
Yes.
Rishi, how much of upward migration and downward migration? You know, the other pathologies like some small osteophytes into the foramina and other things also can be tackled by this?
For calcified discs, we can use that. They have a separate set of burr which can be used, sir. But for calcified discs, I haven't tried endoscopy. So once I perceive it as a calcified disc, I advise micro-discectomy for such patients. For migrated discs, we have done, sir, for both for proximally migrated as well as distally migrated, below the pedicles as well. We are able to retrieve the fragments fully.
I think, sir, to remove the osteophyte also is not very difficult, because as Rishi mentioned, the bevel edge allows you good maneuverability. Like a scope, like an arthroscope, it just goes underneath the dura, and you can use a diamond burr through the scope and you can easily remove the ossified fragment. I think Ayush is also now using a lot of scopes. Ayush.
So it has been very fascinating. I started with what Dr. Rajasekaran does, and we used to do exactly what you do. We used to lift up the flavor And from like till 2017, we were doing that. And with the tubes also, we could do that. Just dissect the flavum, lift it up. And now we have gone to endoscope, and we still could do exactly that. We cut the flavum and we use the tubes to dilate it. So again, the flap is maintained, and and you can almost handle everything as you do more and more. Almost like coming to osteophytes or even the superior inferior migrated disc, what we find it gives you much more flexibility in tackling those. In fact, very recently we did a case where there was a complete osteophyte which is blocking our transforaminal view, and we wanted to use a transforaminal approach, and the whole osteophyte was growing in. What we did is we used navigation, and we used the preoperative CT and intraoperative, and we could track those osteophytes, and using a navigated burr, we could burr it completely and then do our work. So it really opens a different dimension to what you can do, and that is has been our experience. Although we also are still somewhere in the learning phase, but I think it does open better. Like you can really do few more things than what you can do with even with a tubes or through a traditional approach. That is what has been our experience. But there are a few problems that there you could leave a disc small fragment because you really rely on the indirect decompression. The other problem which we have seen is there is a small problem with the reed prolapse, maybe to do with that patient really starts walking the same day, and maybe I don't know, or maybe we are still in the learning phase. So there are some pros and some cons, but as we learn, I think it is where we can do much more than what we do with our traditional approach. That is where I stand.
Yes, sir. You're
Recurrence rates are lesser is probably because of the use of RFA in the disc space. I mean, when you use RFA inside the disc space, it causes burning of the annulus fibrosis and also the disc. I mean, I presume that probably that's why the recurrence is lesser, number one. Number two, infection is lesser, which presumably because of the continuous irrigation that happens. The only thing what we have noticed in our patients, probably I think in our institute we might have crossed 100 cases now. What we have noticed is numbness. Numbness is relatively much more than a patient who has undergone a microdiscectomy. It's probably because of, again, the RFA probably, I mean, we are in the initial phase, like how Ayush said, is probably we are using it very near the nerve root. But the literature also do suggest that the numbness is probably much more in a patient who has undergone an endoscopic discectomy as against a microscopic discectomy.
Is there any difference with the plasma generator or RF system in terms of
No idea because whatever is provided by them is a radio frequency.
RF is what is recommended right now because it
yes,
the
plasma
dissipation
generator?
is less. Dissipation is less. That's what it is.
Okay, thank you. So
A question for the panelists. Do you feel the learning curve is easier with the interlaminar endoscopy as opposed to a transforaminal?
Yes.
And the thoughts on a unilateral biportal endoscopy, which is using traditional, arthroscopes, which are knee arthroscopes, which don't require a separate inventory, because the interlaminar endoscope is a separate inventory with everything.
Sorry. Interlaminar approach is quite easy at L5S1 because you need not remove the bone. But once you come at L4-5, I mean, it's basically essential that you remove part of the bone. You have to see the lateral margin of the nerve root to get into the space. You can't maneuver the scope without seeing the lateral margin of the nerve root. Therefore, there is an amount of bone resection which is necessary at L4-5, which depends upon the interlaminar space. And that's something you need to learn. I mean, my experience is mainly limited to L5S1 and few cases of L4-5. I not done transforaminal. I mean, Ayush does both. Rishi also does both.
okay, thank you.
When we feel it's hard. Yeah, please go.
Okay. Thanks, Ayush. So for want of time, we'll go on to some of the interesting case discussions. And we'll first go on to Aithala because he's discussing something which perplexes and poses a big challenge to all of us when a patient presents with multi-level discs and typical radicular symptom, which is the disc which is the offending one, and what you do for the rest of the discs. So Aithala, can you just present your case?
Yes, sir. Just a second, I will try to share the screen. It's not coming. That come last time. The share screen function is there, no? Somebody has to unshare it.
No, it's all unshared because we are only having this thing.
Okay.
You're not able to get it?
Is it seen now?
No. So otherwise, I mean,
I thought you can send it to us. By the time, I think.
so Naresh,
Yes, sir.
Naresh is going to discuss another major clinical problem. What do you do with persistent radiculopathy following discectomy? How do you tackle it and how do you avoid it?
So, slides visible, sir?
Yeah.
Thank you very much, sir. It's for the nice chance to present our work here after a long time discussing as a fellow again with you. So this is one of the case persistent radiculopathy following discectomy. This is the case details. A 52-year-old male patient who presented with mild back pain, which is on pain scale 2 by 10, at the severe right-sided leg pain, which VAS score is of 8 of 10, and is unable to stand and walk. And there is a pain which is below the knee, and mild paresthesia, and there is minimal knee pain, and there are no motor deficits, and bowel and bladder are normal, and SLRT is 30 degrees. So these are the MRI films on the sagittal. So and these are the axial sections. So this patient has got a severe pain, which is a little out of proportion what we thought, and there is a mild stenosis at 4-5 on the right side, corresponding to the level of the lesion. Sir, it's like, should we discuss now or should we want me to keep on present?
Now, what did you do and what happened?
Yeah, I'll complete the case and then. So this is this is the complete scenario of the patient with radiographs, and this is the one, and this is the L4-5 clinical discectomy. 4-5, we gave right L5 root block, and that gave very good relief. Then we underwent L4-5 micro-discectomy, right-sided L4-5 micro-discectomy. Surgery was uneventful, and patient reported a good pain relief immediately post-op. But mobilized on the first post-op day, it was quite okay on the morning, but I started complaining of severe pain, almost similar preoperative complaints by the evening. Treated with analgesics and oral steroids, no much relief, and then we obtained this is the post-op MRI on the patient. So this is where the approach was done, from where the right L4 root was decompressed. The patient still persisted to have the same complaint. This is the present scenario now, sir.
So that
I just felt that on the L34, was there a small foraminal disc on the pre-op
Can you
imaging?
show the preoperative MRI, Naresh?
The fourth cut on the first row, fourth or fifth cut, is there like a 3-4 far lateral or a foraminal disc on the right side? On the fourth axial cut on the top row.
This is 2-3.
I was just wondering whether we should have, maybe the root block worked because of a partial epidural spread of the drug.
Yeah, that retrospectively, that was the thing. Ayush, want to say add on something?
Yeah, so looks like there might be something like maybe there, like we also see this once in a while, but looking at the image, there could be extra femoral disc at the L34 here. But and again, going by it, if we feel that we'll do a specific root block, we can give just to that because L34 will affect like L3 selective nerve root block to confirm that if the symptoms are coming from there, and if not, then we'll plan it out. And if that is the case, then we can just go ahead and do a extraforaminal discectomy for L34.
Only 3-4, or you do address the 4-5 also, because the pain is below the knee, and also there is some knee pain.
Can you show us the post-operative MRI?
So I just put the 4-5 cuts only here, sir.
Aithala,
Thomas.
Aithala, what do you feel?
So on the pre-operative MRI, there isn't any significant compression, although I understand that the pain is very severe. So I'd be extremely cautious before proceeding with surgery. Would probably give more prolonged non-operative care before I think of surgery. And secondly, I wonder why the nerve root block didn't work as well. So are we looking at the wrong pathology or the wrong level? Is what I would be thinking.
Root worked well, Thomas, but not to the full extent. Not like it's like
Right.
a partial relief with the nerve root. That
Block.
kind of doesn't mean that didn't work, but it worked, but not yet to the full extent, like
Okay.
regularly.
Whether patient had any other comorbidities?
No,
Diabetes?
they are perfectly. Others are perfectly normal. There are no SA joint issues, no knee pain, hip and knees are normal. So this is one good point what Thomas highlighted about if the patient is out of the proportion, pain is the one thing which again we went back and then saw examined the patient quite. Sorry, any comments more or want me to complete? Go ahead.
Yeah.
So sorry, Naresh, was the pain in the L5 dermatome itself?
Yeah, there is in the L5 dermatome and also in the knee pain, also anti-knee pain also is there.
Okay.
So, like Siddharth suggested, then we went back and then gave, we thought initially incomplete decompression, gave L5 selective nerve root block, it didn't work. Then we gave block at L4, that gave him better pain relief. Then we went back with the MRIs and then closely look and you see the L45. Maybe it looks like at L45 there is a foraminal component on the lateral, little lateral side onto the, which is merging with the psoas muscle shadow. So that was one concern. So root block gave relief for 2 days and then started complaining the same pain. So it looked like this. So there is a judgmental error during the initial selection of the approach or decompression. Then we are not very sure whether this decompression at foraminal level will give good relief. So we did we explored and we did a extensive little bit more laminectomy, gone up and down, and then we found out we went with the curved disc punches onto the lateral and then decompressed the foraminal component as well. And that gave good relief. So it was a judgmental error in the identification because it's like a combined pathology of same nerve root, same disc level causing both the nerve root compressions and the L5 nerve root and also L4. So the mistake was we didn't do a femoral nerve stretch test on the day before on the first surgery. That could have actually gave some clue. So any more thoughts, sir?
So,
Go on.
Yeah, so probably pain on the front anterior aspect of the knee should have alerted us to the cause of possibility of higher root compressions. So it's a clinical correlation that is more important.
We were misled by the L5 nerve root block giving good relief. So that was the problem. Otherwise, it would have worked well.
I think your technique of
Spilling over is
overflow into the other nerve root also is an issue. So, but one of the thing is that everybody who has a good number of surgeries being done will face this problem from time to time, and it's also very seasonal. I don't know about Aish and others' experience. You have a very scot-free time for about 7 or 8 months, and suddenly one or two patients sequentially will complain of the same thing, and you wonder what the hell is happening. My professor used to say, if you have any problems in surgery, it always occurs 3 in a row, and then you will have a scot-free time for some time, and then again this happens. But one important thing is, if you have operated on a patient, especially lumbar spine patients, either for claudication or mostly for radiculopathy, and if they are not happy at the time they have to be discharged, I would suggest that you should not discharge them. I mean, these are the patients who are very unhappy when they go out of the hospital, and they are complaining a lot and they are very dissatisfied. And what is the best thing to do is to re-intervene. Don't have an hesitation to explain to the patient, get an MRI done, and tell them that another small decompression needs to be done. But you have to do it before they get discharged. If you discharge them partially happy, then they come back very unhappy after some time, and then to readmit them and to redo these surgeries is a major exercise. So I would actually, I think it's good what you did, that you need to think and don't hesitate to go in and do the surgery and fully decompress. I have always found people who are complaining, if you intervene and you solve the problem, they are some of the most happiest patients that you have.
Yes. So how could have we avoided this issue on the day one?
I think what both Janardhana and Aithala said, I mean, you have to have a clinico-radiological correlation. That clinico-radiological correlation does not mean just that you thought of a disc and he has a disc. The correlation must go to the level of what is the nerve root that is involved. So if you found that the nerve root involved by either paresthesia or by motor corresponds to a different nerve root, and you are tackling in a different nerve root level, or at the same level when you know at the foramen or at the paramedian level, there is a discrepancy, then you need to. If you have found, if you had imagined that, or if you had already diagnosed that it is the other nerve root, then you would have gone into the foramen. And we are actually toying with the idea of getting a checklist done whenever we are doing lumbar spine surgery. And one of the thing is that just make sure that in every single patient you need to get the foramen, check both the nerve roots, and do that. Anything, Ajay?
Yes, I think clinically the patient is symptomatic, and MRI doesn't give. Sometimes when the patient comes to the MRI done elsewhere, you are not exactly certain as to what it is. Either one of the options is to repeat the MRI, just so that you can scroll through the parasage cuts, scroll through the the cuts in your own center. It gives it sometimes a much better perspective, and you might be able to find the pathology. But as Thomas mentioned, be more cautious when you think patient has got a lot of pain, but you are not sure of what it is. Is probably buying time will probably help us to get to the pathology later on.
Yeah. Okay, good. So for
Can I share Aithal's?
Yeah, no, can I share now? I'll try to share now because I changed the internet connection.
Okay.
I have also mailed it to. Can Naresh? Can you unshare?
Yeah, Naresh, you can answer. Okay. Now, Aithala.
So by the time Aithala loads, if you identify that both nerve roots are compressed in this patient, both L4 and L5. So what would be the ideal approach to deal with this
If
case?
you are sure that there is a major problem with the exiting nerve root and there is a big foramen, and on the table that you are unable to do a full justice, TLIF is a very good. You have to remove it, and then whenever you have a problem, don't hesitate to. The worst problem is for we do so many scoliosis surgeries, tumor surgeries, big spinal surgeries. The worst complication is when you have done a radicular surgery for radicular pain, and that day night the patient says, "I have the same pain." That's really devastating. Yeah.
Yes, sir. Thank you, sir. Actually, I think I minimized my screen. That may be the issue. Okay. So now.
Go ahead. So we have 20 minutes to go. So
yes, sir.
10 minutes for you and 10 minutes for Thomas.
First, I would like to thank Rajasekaran sir and the Ganga team for giving me this privilege to be part of this webinar. Thank you all. So this is a common problem that we face in our day-to-day practice. This is a patient, 34-year-old male. He presented to me with low backache as well as radiating pain along the left lower limb, mainly around the knee region. The left knee extension was grade 4 and all other neurological examination findings were normal. Can we go to the next slide here? So he underwent a trial of non-operative treatment in the form of analgesics, spine exercises at his local place for 2 months, but no improvement in the pain. He had severe disability, unable to work for last 2 months. His VAS score was 8 and ODI score was 42. The next. So these are his X-ray pictures. If I can see here, there is a reduction in the disc space at L4-5 and some osteophyte, some degenerative changes here and there, nothing much. Next. So this is the MRI picture. So what attracts us is the L4-5, there is an extruded fragment which is inferiorly migrated. But if I looked at when I looked at the images carefully, there is also another extruded fragment in the L2-3 region. So can we go to the next image? These are the axial images. One can see there is a paracentral extrusion in the L2-3 region and a huge central bulge at L4-5. So looking at the clinical picture as well as the image pictures, I request the panelists to their comments. I got 3 questions. The first question is, we decided to treat the patient operatively. Next. The question 1 is, if surgery is decided, what level discectomy should be planned? L4-5, L2-3 or both levels? And the second question is with regard to the philosophy of the treatment in such conditions when we have 2-level discs. So next slide. The irrespective of philosophy of behind surgical options can be one of these. I need the panelists' opinion on this, which they would like to prefer. Irrespective of symptoms, surgery is decided based on the severity of compression in MRI. Probably after listening to the initial lectures, I'm sure this option is ruled out. Decision to operate is based on symptoms, but once decided, I will operate on both levels, or I will operate on both levels only if they are next to each other, or will operate only on symptomatic levels. So we will discuss with the panelists about these 2 questions. Then based on the answer, I will go to the third question.
Yeah, Naresh.
Yes.
Aithala always poses difficult questions.
So whenever I get a difficult question, and I always give all my answers, select all. So I do all the levels preferably. So because this is a tough case, whatever best you do, the patient is going to have some issues. So give our best, like operate all the 3 levels there, decompress and. Yeah, so that will be the idea, sir. So even if one disc I decompress, maybe symptomatic at the time of presentation, mild clinico-radiological correlation, but once the patient start walking, the other asymptomatic disc may also show symptoms, in the sense that it may not be revealed because of the intensity of compression of the lower level. That's what I feel. So I tend to decompress all the 3 levels again.
Any other difference of opinion from other panelists?
Thomas, you have a different idea?
Thomas,
No,
what do you think is the symptomatic one?
Yeah, I mean, I would go predominantly by the symptoms. Got some weakness of the knee extensors.
That would be L3.
That would be the
left side.
level above, probably
No.
coming from the level above.
No, if you take this is L4, L4, L3,
2-3.
L2, 3. L2, 3 on
2-3.
the left.
Yeah, so it's weakness of the knee extensors on the left, isn't it, Aithala?
Yes. Yeah. Knee extension is slightly weak, and his pain is also centered around the knee area.
No, but yeah, his symptom is on the left side.
Yeah. And the disc is also on the left side at L2-3.
Yes.
I would think that that is the symptomatic level, if you're looking at symptomatic level.
Therefore, which one you are going to approach?
If I would probably do, I mean, if I had to do surgery, I'd probably do both just to play safe, so that I don't have patient coming back with pain later on. But that would be what I would do.
All are.
But basically, he has got a symptomatic L2-3 disc causing a weakness of the L3, which is clinically corresponding to the weakness of the quadriceps, number one.
Yes.
And probably, I mean, presumably based on the presentation, it looks like a asymptomatic left. I'm not sure whether it's a right or left.
Left one.
Left L4-5 extruded disc with the inferior migration. But no neurological deficits. Rishi, what would you do?
Same thing, sir. So if there is a decision to operate, I think better to do both the levels, even though we know that his symptoms are arising from L2-3. At L4-5, probably we need to just remove the extruded fragment alone. We don't need to enter into the disc. If at all I have to enter into a contained disc, then I'd be thinking twice to approach at an asymptomatic bulging level. Whereas if it is an extruded disc, I think it should be okay, but we are going to operate at both levels is better.
Siddharth or Ayush?
Would anyone want to block and see whether the diagnostic blocks makes us wiser in this patient?
Okay. Ayush?
Yeah, I think we'll have to do both. There's no, like, we cannot leave the L4-5 level. Even we know that, as discussed earlier, for the sake of he goes to someone and then someone will see it and tell, oh, they left one. And one more thing, there is some amount of facetal effusion also at in the sagittal cut at L2-3 level. That has also to be considered if we are, because L2-3 the facets are we know that they are a bit crowded, and if you are trying to take this out through a interlaminar approach or an open approach, whatever, the chances are that we might have to do more than what we normally do. And with the facetal effusion, that sometimes comes into play. But so that's just an observation. And
yeah, that's very important.
Yeah.
I think one more thing, so I think there is a lysis at L5 also.
Lysis?
Spondylolysis. If you go back to the SAG, if you look at, just go to the MRI, please. If you look at the parasagittal cuts, where the pars and the lamina are seen, you can see that there's a break here.
There is a suggestion in the lower one, in the second from right.
Top also second from left, sir.
Yeah.
And third from left, there seems to be.
Yeah. So probably that needs to be.
But anyway, the disc is at a level above.
Yeah.
Therefore,
No, just.
Even if it's there is no evidence of lysis or lysis per se.
Yes.
The disc seems to be okay. I think we need to address probably the extruded element of the L4-5 disc on the left and the L2-3 disc. And as we have to take into consideration the facetal effusion in the narrowed space at L2-3, and to decide whether to do a fusion or just a discectomy alone. Because this L3 weakness is is an anti-gravity muscle, and it's a most a significantly important muscle for ambulation.
So what if the patient had an MRI before, which didn't show the upper level, and now it's a new level? So there are a few instances where I ignored the the previous levels, and then the recent onset ones decompress. That will that philosophy work, sir?
I think you have to go case by case. And we always use this famous statement: there is no role for prophylactic surgery in lumbar spine. But that applies only when you are not operating. But when you have decided to operate and you are going to anesthetize the patient and you are going to put a cut on him, then the only thing that the patient wants is he wants 100% success rate. And for him, he will not stand to reason as to say, no, we have been taught not to operate on asymptomatic. I went by your paresthesia, I went by your muscle weakness. He will say, that, no, why, relatives of patient cannot understand while you were there just 1 inch above the other problem, why you couldn't have tackled that also. And so if I were to operate, I would operate both. I would explain to the patient and then operate both. Also, because there is no gross instability in this case, it is not that you are going to operate at many levels and extend the fusion. It is only going to do multi-level decompression. So that is not going to be very disabling for the patient. So the magnitude of surgery is not something tremendous. If you have to extend your fusion into L5, S1 or go very high up, then you need to think about a lot. But just doing a micro decompression and removing the fragments, I won't hesitate to do both just to be on the safe side. It's a belt and brace technique. It's much better to do in actual practice.
Janardhana, it answers your question.
What did you?
Yeah, actually, I had a different philosophy. If you go back to the previous slide, I think I usually most of the times if the level is completely far apart like this, I would prefer to operate only on the level that is affected. Maybe when it is very close and I have a doubt about the level, like the picture which I have put up next. Can we go forward? Yeah, this is another case where it is very close and it is very difficult to correlate and come to a conclusion. In such situations, I would operate both the levels. So in this case, I will explain what I have done. I counseled the patient regarding the two levels, but discussed with him. And next. Yeah, actually, I also had a small doubt about the lysis that Dr. Thomas was mentioning. So I decided not to touch that now and observe it for some time. And I did only the L2-3 discectomy. And at 6 months, patient had complete relief of radicular pain. He is happy, he's back to his work, but he complains of occasional backache at some point of time. So.
Yeah, of course. You have success and failures on either side. It depends on how well you have counseled. If you're aiming to do a single level, you have to spend double the time on counseling and make sure not only the patient but his family understands the philosophy on which you are aiming to restrict to this. Okay, good, Aithala. That's a very good case. Thomas.
Yes, sir. I'll just put my slides up. Sorry. Ooh. Okay. Nearly gave the secret away. Okay. So, are my slides visible? Yeah. Okay. So this was a 64-year-old medical practitioner who had undergone an L4 and L5 laminectomy and discectomy 30 years ago. Subsequently, he was completely asymptomatic and going about his practice till he developed low back pain and right anterior thigh pain in February 2020 or so. And then for that, he underwent an L2-3 discectomy. He did well for the first couple of days and then started developing back pain. So 10 days later, severe back pain. However, he had no fever or constitutional symptoms. And the surgeon who had operated on him initially had put him on oral antibiotics for another 10 days. The only comorbidity that he suffered from was diabetes, which is significant probably in this context. But he's the diabetics in the last 5 years under control with oral hypoglycemics. So he had pain and then 10 days of antibiotics, but the pain continued to aggravate. And it was, severe even with any minimal movement. So getting up from his chair was very difficult. Turning in bed was very difficult. He was unable to even walk or stand unassisted. His neurology was normal. Bowel and bladder were intact. No perianal hypoesthesia. And by the 3 weeks, his wound had healed well. So, can I ask somebody, Naresh?
Thomas, yeah.
What would you do? Severe back pain, no leg pain. So his pre-op anterior thigh pain is gone mostly, but very, very severe back pain. Had 10 days of antibiotics and the wound has healed well.
Okay. So appears like discitis for all practical purpose. Uh, so did you get an MRI first?
Yeah. So diagnosis wise, I'm sorry, sir.
The worst thing is a patient feeling very good first few days, or especially the first 10 days, and then they come back with pain, then you had it.
Yeah.
That's invariably discitis. And the way you described pain many times, very severe pain, cannot stand, cannot move, cannot turn in bed. And once you have seen 2 or 3 discitis patients, the very fact that when they walk into the room, oh, this guy has got discitis. If you have just operated on him 10 or 15 days ago, and if he comes walking in that particular, I call it as a discitis walk. So they are so guarded. You ask them to sit down, they take a long time to sit down, and they will support themselves with both their hands. You ask them to get up, and there is an agony on that face. It's very diagnostic. So everything that you describe.
Points. So clinically discitis. So is that enough? Do you need to do imaging, bloods?
Imaging, because bloods can be this way, that way.
Yeah.
And imaging is, I would suggest it. You don't need to wait for a long term results like culture and other things, because culture
will take time.
And he's already been on antibiotics for 10 days. So culture, ESR, CRP, it will not be decisive, but imaging can be decisive.
Yes.
It can surely give you the diagnosis.
So when he came in, we got some routine blood tests done. His hemoglobin was 11, total count was 10,000, borderline. However, the ESR and CRP were pretty high. So even if you think of post-surgical changes, but 80 CRP and 80 ESR is abnormally high. His blood sugar also was high. He said blood sugar has never been out of range, very well controlled, but ever since this pain started, he's not been able to get his blood sugar under control either. So also got an X-ray done. This is what his X-ray looked like. Nothing very contributory, except, I'm sorry?
The area of level of surgery was
2-3, sir. Yeah. So there is some decreased disc space at that level.
Yeah, some scoli and then narrowed space.
Yes. So that was his MRI. So that pseudomeningocele was from the previous surgery. So we'll just ignore that one. So this was his surgical level here. So that's the T1, that's the T2, and that's the post-contrast. So significant enhancement on the end plates and in the surgical area. So
that's quite close.
I'm sorry, too close, is it? Yeah, I know, but sorry, that was on the previous surgery, and we just closed our, just blanked it out from our side. So,
how to differentiate between a post-operative change and an infection? Can you tell reliably based on the MRI, or is it a clinical diagnosis?
So I think we need to look at 3 things. I think you need to look at clinical, laboratory, as well as the imaging. And all 3 of them should correlate. So if somebody comes with severe pain like this, after an initial period of relief of symptoms, typically his ESR and CRP were elevated, and an MRI showing, florid changes like this on the post-contrast, I think all 3 put together would point towards infections. So that was his, and this is his MRI scans. Any more imaging, any more blood tests or imaging at this stage?
What else? What else you want? PET scan or something?
No,
Nothing.
no. I mean, so it's clear-cut infection at one level. So,
He said he has treated the triangle. I mean,
yes.
for me, for discitis, I would put, if you take 100% for confirmation, I would put something around 70% on clinical and another 20% on imaging and 10% on your ESR, CRP.
CRP and yes. Yes.
So if the image shows a florid reaction, a lot of end plate erosions, some collections within the bone or something, I mean, for me, surgery straight away.
So what kind of treatment would it be? See, just 3 weeks down the line. So the options are with continuing antibiotics, do a percutaneous biopsy culture and change the antibiotics depending on the culture, do a disc debridement / washout, get some specimens at that time and put them on the appropriate antibiotics, or do a disc debridement, do an instrumented fusion and antibiotics. 4 options.
The first option is straight away ruled out, Thomas.
Okay. Fair enough. Because he has had antibiotics previously, or because the pain is severe, or?
No, in the current era where we talk of antibiotic stewardship, there's no role in an established infection. There is no role for giving antibiotics just like that.
No empirical antibiotics.
No empirical antibiotics.
Fair enough. What about a biopsy and culture and antibiotics?
Waste of time for this patient. This patient severe pain. I think you just need to go
in and
fix and debride.
I think we are a biased crowd, being all surgeons.
Siddharth.
No, I still feel that post-operative discitis, I think there is a role for wait and watch with antibiotics. Quite often the patient is not willing to wait because of the pain, and then sometimes he might ask you for the surgery. You can discuss the options of surgery, but I think there is still a role because most patients with discitis will eventually fuse. If you get the bug, it's the big bonus. So when the patient is willing to take that biopsy option, or whether by chance we get something on blood culture, there's no harm in sending the blood culture. It might show something on the 3rd day of growth, which makes you wiser in terms of choosing the right antibiotic. Right now on the X-ray, there's not much instability. I don't think it warrants a fusion. But if the patient's very bad, then maybe I would offer debridement. I think these cases, there are a lot of new papers which suggest that just a transforaminal washout with the type of endoscopes, you decrease the infective burden, you give a better chance for the patient to get better in the meanwhile, and you continue with the antibiotics. It also helps you get a larger quantity of sample. Maybe it isolates the organism in a slightly higher rate of culture positivity.
So Aish, what would you do?
In cases we have tried what Siddharth said, endoscopy washout sampling, and it has worked well. But still, we have mostly tried in patient where we thought they are not very fit for a fusion surgery or something like that. But still, I will say 70% of the case we go with what most of you guys said. We use a percutaneous screw and just a debridement and pack the space with bone graft. But we have used what Siddharth rightly said. Our confidence is still not up there that we will use endoscopic debridement and washout for all the cases. But it has worked in the cases we have tried.
Okay, my opinion is that if you had operated on a patient on the disc for pain, and if you thought that his pain level required surgery, and when he comes back with more pain, because discitis pain is more alarming to the patient than his original pain, and that's what alarms him terribly. And the discitis pain is not only a pain for the patient but also for the whole family. The whole family is completely distraught because of the very severe pain.
Surgeon also, sir. For surgeon also, it's painful.
If you have a discitis patient and you know that you are going to enter his room is 3 rooms away, your heart actually comes down itself from now itself. You know that you have to go and see his wife is going to be so worried. And so, scientifically speaking, I think, if you get a blood culture, if you get the bug, and then if you kill it with some antibiotics for over a period of 2 weeks or 3 weeks, it will prove that 6 weeks of antibiotics will cure this problem and all that. But what to do with the patient for those 6 weeks? That is a major issue, and he's in a lot of suffering. One quick way is when the patient is very much suffering in pain, he and his family are always willing for a surgery. When they are in very much agony, you tell them, okay, it's probably an infection. There is a bug. I don't want this to extend. It might become more. It will be a quick fix if we can just operate. It's a small surgery. Don't worry. You reassure and you do it. They are plucked. Next day morning is absolutely normal. And that's really very good. Otherwise, this up and down surgery, he says in the morning he's slightly better, but afternoon his wife comes running down and says, oh, he went to the toilet and he couldn't get up from the toilet. 4 of us have to lift him up. This will be a big problem. On a practical scale, leaving apart science, I would just, any discitis over a period of time, and in this last 25 years, we have had experience with a lot of discitis. So ours and others, the surgery, always debride, but debride and fix is very important. Because when you debride discitis, there is a certain element of instability that you leave behind. So you must always fix. You fix, then you're quite happy. That's everybody is happy from the next day. So this is just a practical experience. Nothing wrong in what the other thought process of getting more sample, getting a bug, and then giving a high dose of antibiotic is also, technically okay. But this one takes a lot of weight off your mind if you're the treating physician.
So I also agree with that. Actually, I have tried both the methods like percutaneous aspiration, culture, and biopsy, and I'm able to solve the problem or control the infection. But most of these patients, they would have had severe disability lasting up to 6 to 9 months. It takes nearly 6 to 9 months to make them get up, walk properly, and get back to work. And that persistent pain, while in those patients where I have tried fusion, they were able to back to work within 6 to 8 weeks with good pain relief. So that is one observation I have found out. Anybody else have the same observation or?
Yeah. I think fixing makes a big difference to
gives
the immediate pain relief.
Yeah, the infection settles, but it takes nearly 6 to 9 months.
Sure.
You have to counsel them repeatedly and.
Thomas, also this post-op MRI shows some retrolisthesis also. You can show the MRI.
Yes. And this space is collapsed also.
So I am quite convinced with the fixation and because the end plates which are eroded with the infection, the movement and rubbing on each other cause a lot of pain. But I'm still not confident like what Sar does, putting a cage also in case of infection. So that requires really a thorough debridement and complete maybe like radical debridement and then putting the cage. Maybe some thoughts of Sar on this. So how comfortable are you to put a cage in an infected space?
Okay, so most of these cases will fuse by themselves, and if you actually fuse, if you stabilize them, not fuse, but if you stabilize them with screws, they still fuse. But the problem comes when already the bone has eroded about 20% above and 30% below, and then the gap is quite a lot. And then you have two options, either to debride quite a lot, you can excise the facets and then shorten the spine, shorten the disc space, collapse the disc so that you make it very short and then it will fuse again. But if you find that it is not possible, then you have to do a very thorough debridement. And we have now, I don't know, Ajoy and Rishi can say more than 100 cases where we have then put in a cage in presence of infection. Our first 28 cases were published long ago. But if you have to do that, your debridement must be very good. So in those cases, what I do is you have to debride from both sides. You should not debride from any one side alone because you might leave a pocket of infected disc material on the other side. So you have to do a transfacetal good debridement on both sides. And if you use the microscope, you can just see very nicely inside the disc space and you can be very good. You can completely clear out. It's all the same thing, like whether in infection in the tibia, whether you can fix with a titanium plate, use of metals. So I have no hesitation if I think that the gap is too much and if I have debrided well, we still go ahead and put in a cage.
So one more serious practical question: when to stop antibiotics in these patients? Because once you fix them, they are quite happy in terms of pain. Uh, any criteria like ESR, checking ESRs or CRP or clinical parameters, when to stop an antibiotics in on post-discectomy fixation patients?
Yeah, Ayush, what is your criteria for that?
We do monitor the various levels, but at least what we do is give up to 2 weeks of IV and again continue over 6 weeks of antibiotic we give. But we do monitor with ESR, CRP, and quantitative CRP does give you idea if how the infection rates are coming down. And if you see it has come down, we stop at 6 weeks normally. But if you feel that it's still on a higher side, we do individualize it, and sometimes we do discuss with infection specialists, and they do give their own inputs into it. But 6 weeks for sure, irrespective of what happens. And CRP, quantitative CRP does give a guideline of when to stop it.
It would depend on whether you grew a culture or not grew a culture.
Yeah, that also will play.
It's a positive pattern. You can wait for usually around 6 to 8 weeks could be sufficient. If you got a culture negative and then you based on empirical antibiotics on the region, depending on the culture pattern in your center, probably it's safer to give it for at least 8 to 12 weeks time. And no fixed studies have shown 6 weeks is adequate, but most of the studies which have shown 6 weeks is adequate is basically based on culture positivity which they have got.
I think it makes a huge difference if you know the enemy. So if you have a bug, then 2 weeks of intravenous antibiotics and 4 more weeks of oral antibiotics.
The other practice, what we usually do is that we prefer to give 2 antibiotics, at least for the IV period of 2 weeks.
The empirical things, empirical antibiotics.
So even if it's a culture positivity, if you have grown a culture positivity, we prefer to, there are 2 antibiotics that the individual organism is susceptible to. Always find the response is better. I don't know whether it's too much or not. I think Aithala might criticize me.
Anything when you get the culture report, we always get that MIC. Does it determine your choice of antibiotic when you select one?
It does.
It definitely helps to select the antibiotics.
Get the highest MIC and then go down. Hit it fast and hit it bigger.
The reason for asking this is the 2 of my patients who missed out antibiotics after 10 days, but they went on to fuse without any issues, because maybe the fixation makes all the difference, or the debridement what we do makes the difference.
I think the surgeon and the debridement made the difference.
No, but we have seen that in tuberculosis also, patients who may have diagnosed biopsy-proven tuberculosis, take the drugs for 2 months, stops, comes back after 1.5 years, you find everything is healed.
Yeah, putting screws will be very difficult in those cases.
You don't know whether it's what works.
So with antibiotics,
all the patients, that's the fact.
So this you're not fusing. When you're not fusing or fixing, then there is it's a good thing to 6 weeks to 8 weeks that all protocols work. Even after debridement, so any fixed guidelines are
No, you see, if you go to the British protocols, they are asking for 12 weeks of intravenous antibiotics. And 12 weeks of intravenous antibiotics, and they say there is no proof that surgery does it better. And that they compare at the end of 6 months and say at the end of 6 months, both groups did well. But it is like saying when you have a very bad disc prolapse, like the Wardle series, I mean, they exclude all the serious ones and they say at the end of 2 years, surgery did not have any benefit over the non-operative. But we are not worried about, I mean, how can you tell a patient after 2 years you will be all right? So that's not an issue. So I think you should give 2 weeks of intravenous antibiotics and then switch it over to oral, and that should be fine. What do you do, Thomas?
Go ahead, sir. So by the time I saw the patient, it was 2 months down the line. And in the meanwhile, he'd had multiple courses of oral antibiotics. And when he came and saw me, he had significant weakness in both lower limbs. So this is what I went ahead and did. So because it was 2 months down the line and his pain was excruciating, so I planned for a disc debridement, instrumented fusion, and I packed the disc space with some local bone graft. The bone was extremely soft, so put some transverse connectors. For extended infections, we normally go do 2 levels above and below instead of just 1 level, just to be on the safer side. So this is what we did. And then sent the specimen off for aerobic culture, anaerobic culture, gene expert, and histopath. So I'll just go through what the report showed. Anaerobic culture, there was no growth. Aerobic also, there was no growth. Gene expert was negative. Histopathology said negative for malignant cells, granuloma, and fungal hyphae. So fortunately, we picked up something on the blood and urine cultures. The urine culture grew through 2 organisms, Pseudomonas and Klebsiella, and the blood culture grew staph, coagulase negative staph. So we had plenty of organisms and antibiotics to choose from. So fortunately, I work closely with the infectious diseases team in the hospital. So they take a call on the antibiotics. I mean, we chat about it, but exactly what antibiotic is to be given, they take a call. And typically we give patients 6 weeks of intravenous antibiotics followed by 6 weeks of oral antibiotics. And we look at recovery based on the 3 factors which we use to diagnose the infection. Number 1, clinical. Number 2, laboratory parameters. And number 3, the imaging. So 3 months down post-surgery, yeah. So he was, 2 months of infection. He was quite, badly off. So we gave him plenty of protein supplements, got his albumins up. But 2 days post-surgery, he was able to walk around without too much of pain. So that old instability kind of infection pain that he had settled down. And we followed him up clinically and using laboratory parameters. And at 3 months, he was happily walking around back to work as a medical practitioner, normal neurology in both lower limbs, and his blood parameters had come back to normal, and his blood sugars also were more easily controlled at this stage. So,
yeah.
Just can I ask you, sir, for an early discitis, would you do 1 level fixation, or would you go above and below, or what is your thing? 1 level.
It's gone for 1 level. The decision to go to an additional level above or below is not depending upon the infection, but depending upon the bone quality, if it is very severely osteoporotic, or if the bone destruction is very high. So, then if nearly 40% of the bone is gone or something like that, then I would go for an additional 1 more level. But otherwise, here you have almost got bone-to-bone contact.
Yes. No, I put some bone graft in also. Yeah, but the disc space the height had reduced considerably. Yeah. But his bone was very soft because he was literally bedridden for 2 or 3 months. And so that's why I had to put these cross connectors also, because my screw hold was quite tenacious.
No harm at all.
Yes. So that's the end of my case.
Yeah, that's a very interesting case. I mean, discitis is a very, one of the worst complications you can get after this surgery. But as you have more and more discitis in your practice, that's nothing to be so much worried about because it is completely treatable by good debridement and stabilization. That's a good option out.
A few insights on the patient also get the wound infection along with the disc space infection, pus pouring out from the wound. Those things in the day one fixation, or you want to wait for some time and do the fixation later?
Yeah, you can actually do a very good debridement and put some cement beads and wait for some time and then go and fix. But if the actual bone at the place where you're fixing the screws are not affected, I would still do a very good debridement, stabilize the bone. That stabilization is so comfortable and convenient for the patient. It just changes the pain for the patient. If you do a wide debridement, take off more bone and damage more muscles, and then you leave him like that, the pain factor is not gone. So I would actually even fix it. And if you're worried about the multi-tissue infection, leave it open with a vac for 2 or 3 days or a week and then close. But my high priority is in a very thorough debridement and stabilization.
Also, few cases like there is a keep on ascending infection. Like if you debride one case, one level, and then fix it that level, that will do better. But after some time, then the next level comes up.
That is a problem with the immunity and general condition of the patient. We really have, I forget his name, but that infection went up to 4 levels. Ajoy might know the name. It came with 1 level and he went up to 4 level. And the only thing that stopped was very thorough debridement and fixing all the 4 levels. He became okay.
Any reforms in sir?
See, the Siddharth knows. Siddharamaya is his name. Yeah, it's a famous patient. He just went from 1 level to 1 level. And the only thing that gave was a good thorough debridement, and we fixed all the levels. He just healed like that.
But Naresh, it also highlights the importance of doing a blood culture and urine culture, because of more importance is a blood culture positivity. Therefore, any patient who comes to us with the infection is always mandatory that you do a blood culture and urine culture, because if you are able to get an organism from somewhere, or whichever a culture positivity you get, the response is much better than a culture negative patient.
First principle of battle is know thy enemy. If you know the organism, everything changes. It's a huge thing. It's the same thing with total hip or total knee infections. The only thing that matters most is do you know the organism.
Do you do anaerobic cultures routinely, sir?
Not available in Coimbatore. Therefore, you don't have a choice.
The anaerobic, for some of our experimental work also we have been trying. It's very difficult to get anaerobic culture in India. I'm not even sure whether it's available in Bangalore.
No, we do routinely, sir, for the infected patients. So the thing is, we get the culture tubes to the OT, and the specimen is put directly because they can't survive in an aerobic media. So we put the specimen directly into the culture media in the OT itself as soon as we take it out.
And what are the anaerobic organisms that you grow?
We haven't grown much actually. We haven't grown any, but we do it as a routine, sir.
Because that's it's a very wide subject, because now I am reading a lot about microbiology on this infections, subtle infections and subclinical infections. These anaerobic organisms are a very different kind of animals by themselves. So use the same principles that we used to treat for them to identify. But I think we are Ashok is very hospitable to us, broad-minded that he has allowed us to overstep our transmission time by nearly an hour. So, Ashok, I should thank you for this, and thank you to every one of you, all our alumni, Thomas, Siddharth, Naresh, and Aithala. And Aish, thank you very much for joining us and for your wonderful inputs. And thanks to every one of you for joining us on this interesting topic. It always starts with the lumbar disc, but the problems that the lumbar disc can give to the surgeon is to the patient and to the surgeon is tremendous. So this is the second in the series of the Ganga webinars. The next one for the next month will be on trauma. And you will have from Ashok an inquiry of what is the subject that you would like to in trauma, and we will be very happy to have the webinar on that topic. So thank you to all of you. And good night.
Thank you.
Thank you, sir.
Thank
Thank
you.
you.